And make sure everyone's muted unless they're speaking. Let me know when we're live. Thank you so much. So good afternoon and welcome to the first interim briefing for the House Health and Government Operations Committee. And also we are joined by the fabulous chair of the Health and Human Services Subcommittee for the Appropriations Committee and her members as well. And we're going to do this jointly today. We're honored to have the Health and Human Services Subcommittee join us. And before I go on to giving my remarks, let me allow Chair Chetty to say a few words. Chair Chetty.
Thank you, Madam Chair. I want to take the opportunity to thank the Health and Government Operations Committee for allowing the Health and Social Services Subcommittee of Appropriation to join today. We're honored to have the opportunity to be a part of the discussion and love the partnership between our two committees and value it deeply. This program with self-directed services has reached many of our inboxes. We've been hearing from many constituents about some of the recent shifts within the program. And we're grateful for the opportunity to hear from Madam Secretary and Deputy Secretary Hutchinson, as well as a number of really important advocate voices to hear about what's working well, what some of the challenges are, and some opportunities for improvement. Really want to take another moment to just express the importance of all of us to keep this conversation productive and civil. We all care deeply about this patient population that is served by these programs, and really want to come to a solution that serves everybody. So thank you again, Madam Chair, for for the opportunity for us to join you. And I just want to introduce, just because there's so much fewer of us on HSS, Vice Chair Delegate Dana Jones is here, she can wave, and Delegate Alethea McCaskill, as well as Delegate Jim Heimbaugh. Thank you.
Thank you for being with us. We appreciate you. So we also are honored to have with us today Delegates Partisan, Guyton, Wallach, and Arentz, who have been working with constituents and the committee on this matter as well. This is a virtual briefing, so I ask for your patience if we encounter any technical or streaming issues. It happens, but we will deal with it. This briefing is being streamed on the Maryland General Assembly YouTube channel. Members will be muted throughout this briefing. If you have a question after the presentation, please use the raise hand function, which is located either underneath the participant list on the right side of your screen or under the reaction bar at the bottom of your screen. After I call your name, please unmute yourself. Remember that even though we're meeting on Zoom, please refer to our usual committee rules we have here on HGO, which is one question and one answer from the panel, not one question and one answer from each individual panelist, so that we can get out of here by 3 o'clock. That is our goal. And also, please keep your questions brief. Remember that we'll be dealing with this during session. So this is the beginning of the conversation, not the end. Today's briefing will begin with the Department of Health, followed by representatives from Financial Management and Counseling Services, support brokers, and self-directed service participants. Chair Chetty and I try to be really inclusive and diverse of everyone that is affected. Before we begin, I want to thank all of you for being here today to discuss this important issue. Understandably, as Chair Chetty said, this is an emotionally charged topic, and I want to acknowledge the significant personal and professional stakes involved and express my gratitude for the courage and commitment of everyone present. We do understand what you're going through, but we want you to give us the time to try to fix it. This briefing is an opportunity to have an open and transparent dialogue. I encourage each participant to speak freely and share their experiences honestly. Share your experiences honestly. I'm repeating that again. This is your opportunity. We can only do meaningful work and craft effective solution if we have a clear understanding of what the situation is really like for all the parties. And please, let's be respectful. Let's not be disrespectful. Let's be kind. Let's be humane. and give us again the time to fix this. So let's get started. Chair Chetty.
Thank you, Madam Chair, again, for the lovely remarks, and again, for grateful for the inclusion of our committee. So we'll begin with panel 1, which is our Department of Health panel. And we have 2 witnesses on the panel, Madam Secretary Laura Herrera Scott and Deputy Secretary of the Developmental Disabilities Administration, Marlena Hutchinson. You may proceed in whichever order you prefer. Thank you.
Good afternoon, everyone. I think, are we bringing up our slides or I just need clarity? Oh, great.
We are.
Okay, great. Thank you so much.
My pleasure.
And I just want to apologize in advance. So I'm going to stay on for the first hour, but then unfortunately we have a cabinet meeting. So I'm going to race over to State Circle, but I will not be able to stay on for the whole time. But Deputy Secretary Hutchinson will be on, as will Sarah Case Heron. We'll be on the rest of the time, and we'll take any additional questions for the record to get back. So I'll apologize in advance that I can't stay on for the whole time. So we're going to be providing an overview and updates on self-directed services. But first, I want to just say, self-directed services allows for greater individual choice and control, and that has always been the intent of the program. And, it works that way when it's thoughtfully designed. But unfortunately, in the past, the one-offs has not has enabled staff that was not sufficiently trained, inconsistent documentation, and our program does not align with national best practices. We are definitely an outlier compared to other states, and so we have been working diligently in the time that certainly I've been in offices in aligning our program with other state best practices and relying on my colleagues in other states and learning from them. And the way we're doing this, if we think about training, is support worker training. We announced earlier this year in May, we gave an extension to all support brokers on the annual training that's required. Put out the training again in October as a reminder. We have 729 support brokers that are in need of training. To date, 139 have completed that training and have passed. We have 247 that have started but have not completed that training. And we have 343 that have not started that training yet. And that training is due by the end of the year. Can you please stay in the first slide? Thank you. And so it's really, really imperative that that training be completed before the end of the year. It's vital, the way we have on the traditional side with certifications and licensure requirements, that training be completed. We are also looking at our CCS agencies. That's certainly been flagged by many of the participants, the need for better training for our CCSs and the conflicting guidance. So we're now conducting monthly technical assistance meeting with our CCS agencies, and we're developing a training series based on what we're learning from those technical assistance meetings. And the training services will complement and build upon the current based upon the current training that we're doing. They will be comprehensive in nature so that CCSs understand how to support individuals in all 3 DDA operated waiver programs. So a lot of training and supports are underway to make sure that everyone who is supporting someone in self-directed services understands the rules of the program, so we're advising participants appropriately. And with that, I will now turn it over to Deputy Secretary Marlena Hutchinson. Marlena?
Good afternoon. Thank you, Secretary Herrera Scott, and thank you, Madam Chair Pena-Melnick and Madam Chair Shetty, for having us here today. We are going to just do a very high-level overview of the self-directed services updates that you all have been hearing about since we actually published our updated policies and procedures manual. The key takeaways today are we just really want to leave you all with the department's ongoing commitment to the 3 DDA operated waiver programs. We are responding to stakeholder feedback regarding the inconsistencies and lack of clarity by publishing these clear and unified standards. We are in a process of evolving, and as our waiver programs expand and evolve, the infrastructure should be designed to support participant self-determination, regardless of service delivery model. So in doing this, we definitely need these clear standards. They are essential for quality services and program integrity. Next slide, please. The next slide just gives a basic overview of what I'm going to talk about today and be able to provide any answers that you may have as a result of the topics that I cover. So I'm going to give a high-level overview of Medicaid waiver programs. DDA operates 3 Medicaid waiver programs, give a quick snapshot of our current self-directed services enrollment, the goals of the updates for the policy and manual that we published on October 24th, and then an overview of those updates and changes. Next slide, please. So as I mentioned earlier, currently Maryland operates 8 1915C Medicaid waiver programs. DDA, of those 8, operates 3 of them. They are community pathways, community supports, and family supports. Medicaid waiver programs allow us to waive certain Medicaid rules, such as income, and target specific populations so that individuals who would otherwise need institutional services, they can actually be served in their communities of their choice. For Medicaid waiver programs, participants must meet financial, medical, and technical eligibility. Next slide, please. For our Medicaid waiver programs, we offer 2 service delivery models in all 3 of those programs. And they are the traditional services model, which is actually administered by our community providers, and then the self-directed services model, where the participants or individuals, they have served as their authorized representatives, help them be the employer. So individuals in the self-directed services model actually perform the activities as the employer. For example, they hire, fire, and train staff. Also, individuals in the self-directed services delivery model, they have budget authority, which means they control how their money is spent within their approved budget. I mentioned earlier in regard to the criteria for waiver participation. Because states petition the Centers for Medicare and Medicaid Services to basically demonstrate that these services can be provided in the community instead of a institutional setting, waivers must be cost neutral. And so what that means is the home and community-based services must cost less than the comparable institutional costs. For the 3 DDA operated Medicaid waiver programs, our institutional alternative is the intermediate care facilities for individuals with intellectual disabilities. Next slide, please. I spoke a little bit about this in regard to our service delivery models. We provide these 2. I'm not going to read these slides, but basically it shows you for the self-directed services model how the participant acts as the employee, and how on the traditional side, our community providers are the employers of those services. And for both models, regardless of the service delivery model, again, we are about empowering the participant having control over their own person-centered plan. Next slide, please. This is the brief snapshot in regard to our current enrollment by service delivery model. And so as you can see here, we've had some growth within the self-directed services delivery model. On the traditional side, starting from 2021, we were at enrollment of about 259 participants. And as of the close of fiscal year 2024, we were at 16,827. The comparative here with self-direction as of in fiscal year 2021, we were at about 1,618 participants. And by the close of fiscal year 2024, we are at 3,632 participants. So this is just a snapshot as to how both service delivery models are evolving over those fiscal years. Next slide, please. The goals of the updates for the policies and the procedure manual that we have. So basically what we did, we heard from constituents in regard to accessing information, DDA's policies. And at one point in time, our policies were obtained by a number of ways by way of our website. So what we did is we consolidated all of the policies on our website so that individuals accessing or wanting to access the policies could have a one-stop shop. And with that, we also made certain that our updates aligned with the federal laws and guidance. And we also checked against the Self-Direction Act of 2022. My apologies. We understand that we've been hearing some concerns about the request for more documentation, but we just really want to stress that these changes are needed to provide the appropriate funding for each case. We're also doing this to reduce the processing times that we've been hearing from participants and constituents, and also to address some concerns that have been flagged in audits and investigations. We are confident with this information will reduce the extended back and forth that participants and their families have experienced when making person-centered plan determinations. Next slide, please. An overview of the updates. So we've been talking with our various community partners about the updates to the policies. And we want to just be very clear that there are no changes to the services or the array of services to participants, but we do need the documentation. And it's needed because we are receiving requests in regard to paying staff more than the established maximum by way of our reasonable and customary charges, allowing family members to work overtime, accessing optional goods and services through the individual and family directed goods and services waiver service. We've also made updates to our invoice timesheets as required by CMS standards. Again, we're confident that this increased documentation means a cleaner and clearer and shorter approval path or denial for participant service requests. Prior forms only required a mere attestation of the participant having the documentation to support the need. We also know, just by way of the legislative audits and other audits that we have experienced, that documentation is a critical source of program integrity, and it assists the department with assuring that participants' health and welfare needs are being met, and also addresses those concerns raised in any audits. Next slide, please. So the other thing we are providing clarification on is the understanding of the reasonable and customary standards. And so this chart just basically displays that the employee wage rates cannot be changed for a date in the past. So we published this chart for everyone's situational awareness. Some of the requests that we've received is requests for wage increases that happen retrospectively. We also have provided clarification in regard to holiday wages to make sure that they do not exceed the reasonable and customary wage range as well. So this is just the chart for everybody's situational awareness. Next slide, please. In regard to the individual and family directed goods and services form, we updated that form so that it would be more user-friendly for the participant experience. So it's now a smart sheet. It also must be submitted by the participant's case manager or the what we call the coordinator of community services. And it also details those additional documentation requirements that are outlined in the updated manual. Next slide, please. The wage exception form, this form is used to request a higher wage than what's in our reasonable and customary standard, as you saw in the chart, the previous slide. We also are asking that this be submitted by the participant's case manager or coordinator of community services, and also requesting that additional documentation to be submitted when the wage exception form has been forwarded to the department for consideration. And with that form, the additional documentation requirements are around the job position and the employee's qualifications. Next slide, please. Family of staff overtime requests. So we clarified that no relative can work more than 40 hours per week per participants across all waiver services. We do understand that emergencies happen, so a relative may be authorized to temporarily work more than 40 hours a week. And then all requests for family members to work overtime must be requested to DDA and approved by the DDA. Next slide, please. So that is a high-level overview of the updates that are reflected in our policy and manual. I am going to turn it over now to Secretary Herrera Scott to close out the department's presentation.
So thank you, Marlena. So we did want to open it up for questions. But before I do, we did get a few questions about rare and expensive case management, or REM. And I just want to be clear that REM is not part of DDA. DDA is a Medicaid waiver, and it's for habilitative and rehabilitative services. And REM is medical case management for individuals with specific medical conditions. And those medical conditions are defined in COMAR. And to be specific, it's 10.09.69.17 and is based on specific ICD-10 codes. And it includes things like HIV and hereditary factor VIII deficiency. So it's a very specific program that requires medical necessity criteria to meet the participation in the program, but that's on the medical side, and it's a Medicaid program, not a DDA program. So I just wanted to make the distinction, since we've gotten some questions about REM and DDA. And with that, I will turn it over back to the chairs, and we'd be happy to answer any questions.
Thank you, Madam Secretary. Thank you, Madam Deputy Secretary, for your presentation. Very informative. We'll start by recognizing Delegate Jamila Woods for a question. Delegate Woods, you need to come off of mute, please. I'll give her another second or two. Delegate Woods, can you hear us? Okay. I will, while we wait for her to work out her audio, I'm going to ask a question, please, if I may. And then I see there are a couple of other hands raised. So maybe I'll defer my question for now, and I will start with Delegate Heather Bagnall.
Thank you very much, Madam Chair, and thank you to the department. I just wanted to ask a clarifying question because I know this has come up and this was helpful for us to sort of understand because there's often confusion about a case manager versus coordinator of community services, and it sounds like they are the same thing. So in a previous briefing, we learned that if people had questions about their documentation, they should go back to their coordinator of community services. But I think at the beginning of this briefing, you referenced that not all of the coordinators are trained. So who's responsible for that training? And if they aren't trained, is there another avenue for families to determine what how to suss out this documentation if they're not getting correct information from their coordinator of community services?
So I'll start, Delegate Bagnall, and then I'm going to have Marlena jump in. They are all supposed to be trained, but through these technical assistance meetings, the weekly meetings that Marlena and her team are having, we're finding that there are deficiencies in that training depending on when they've come into the role of CCSs. And so that's the work that Marlena and her team are doing to assess the adequacy of their training, their knowledge of the rules of the program, and developing competencies moving forward to establish the full floor, for lack of a better description. So we're owning our side as some deficiencies, and it's not throughout, but we are identifying deficiencies as part of this process. So Marlena, I'll turn it over to you.
Yes, Secretary Herrera Scott, thank you for that. So yes, Delegate Bagnall, our CCS, they are trained, and participants are to work with their case manager / CCS. As the Secretary said, we've been hearing from the community, and by way of our technical assistance conversations with the various CCS agencies, we understand that there are deficiencies. This is also an area in which the department received repeat audit findings as well. So we're taking a very deliberate approach into making certain that we build a training series that complements exactly what the support broker training series is doing, to make certain that the CCS are aware from a comprehensive approach of how they are to support participants regardless of service delivery model. And with that, we to answer your earlier question in regard to who participants can reach out to, their CCS or case manager is the front line, but the department is also here for them as well. In each of my regional offices, we have leads called CCS leads who also work with participants and families, advocates and so forth, who call in and have questions about the person's services, their person-centered plan, and so forth. So what we're doing is we're shoring up the infrastructure based on the community's feedback to make certain that all bases are covered to enhance the participant experience.
Thank you very much.
Absolutely.
Thank you. Recognizing Delegate Jennifer White Holland for a question.
Thank you so much, Madam Chair, and thank you all for the opportunity to share space with you and to learn more about these particular issues. The one question that I have, and I appreciate you all spelling out the variety of changes based on the identification of deficiencies to make things more efficient, to align with federal standards, along with previous legislation passed. But it would also be helpful here to better understand what did communication look like, especially to those the impacted population, and how were advocates and those receiving these services involved within this process. I think based on some of the correspondence that we received, it felt like it sent shockwaves through the system. And so just wanted to get a sense of, as we are working to create greater efficiencies, how is this informing how we go about involving and ensuring that people are involved with some of these changes? And so if you could just spell out what did those communications look like, and how people were involved in the process, and if not, how are we moving forward differently to ensure that there's greater collaboration in advancing some of these changes.
So Secretary Scott, I can take that. Thank you so much, Delegate White. So what we learned in this process, we started by working with the individuals who actually support participants, again, understanding what those needs are. And so this really started as a result of us building up the support broker training series as we were ramping up for the certification. We published the updated policy and manual on October 24th, and it had a 2-week window for individuals to be aware of these updates. Again, it's a compilation of our existing policies and to communicate to the broader community how the department was reacting to the feedback that it had been receiving for some time. As we published it, we did start hearing some very constructive feedback from community partners. And what we learned is we could have done things differently. We could have done things better. We have committed to making certain that everyone is acutely aware of our processes, our updates and so forth, because we have we started in October our first Medicaid Waiver Advisory Council meeting. And yes, the manual was published after that meeting. But again, by way of the feedback that we've been hearing from our community partners, we've established additional platforms for community engagement, stakeholder involvement, and so forth. So we're going to be very honest about we could have done things differently, and there's always room for improvement. But we have established various platforms to engage with the community moving forward.
Thank you.
Thank you, Delegate White-Holland. Recognizing Delegate Leslie Lopez for a question.
Thank you, Madam Chair. I saw on one of the slides a few back that there were federal changes that our state policy needed to align to. And I've just like everyone here, my inbox has been blowing up with concerns about things, but this is the first that I've heard that this is a result of federal changes. And so I want to give you the opportunity just to explain in a little bit more detail about what those changes were.
So there were not any federal changes. What we're doing is these are federal authorities that we are making certain operate accordingly. So what we did is, again, we compiled the existing policies that were complementary to our federally approved authorities into one policy and one manual. And we did that to clarify for the community exactly what those federal authorities mean. So there have not been any changes to the federal authorities at all. That happens by way of an amendment process that would be published for comment a minimum of 30 days. So no policy, no federal requirement changes, just making certain that our processes are in alignment with our existing federal authorities.
So Delegate Lopez, just to give you an idea, so such as, as the employer of record, there are certain processes around timesheets that we need to follow, and that's such as signing a timesheet. So there are things that were not being followed throughout. So adhering to some of those processes. Another thing that we're supposed to be doing is around cost neutrality, which we've deviated far from. And so making sure that the budgets and the needs described in the person-centered planning are as close to cost neutrality as originally intended in the waiver application that we submitted. So those are the kinds of things. So it's not net new, but it is the waiver application that we submitted that CMS said, yes, you can operate for this population separate and apart from the Medicaid, from the rest of the Medicaid population under these terms. And we had deviated from the waiver application that we have today. So it's just moving us back to the Medicaid waiver application that we're supposed to be operating under.
Thank you for the question. I'm going to try again with Delegate Jamila Woods. Have you sorted out your audio? Are you available for question? Okay, I don't think she is. So I will go to Delegate Ken Kerr next.
Thank you,
I'm
Madam.
sorry, I apologize. I'm gonna put my hand down.
Oh, okay. Are you sure? Did you have a question? You have it up for
No,
why?
I'm good. I'm good. Thank you so much.
Thank you, ma'am. Okay, Delegate Kerr.
Thank you, Madam Chair. Deputy Secretary, am I understanding correctly that these are changes made because previously you were not in compliance and these bring you into compliance with federal regulations?
There were some things that we did not do in compliance with the existing federal authorities. And for the most part, these updates were to clarify exactly what those federal authorities are. Again, in response to stakeholder feedback, as we are reviewing person-centered plan requests, understanding why we're asking specific questions, why we're asking for certain documentation, to make certain that we are aligned with our existing federal authorities.
Thank you. Recognizing Delegate Michelle Guyton for a question.
Thank you so much. Thank you for being here, Secretary, Deputy Secretary, and thank you so much to the Madam Chairs for inviting me to this meeting. I just have a question. I think one way to look at this entire problem is that we have an incredible shortage of direct support professionals, both in traditional slots, which may explain the reason that more people are going to self-directed because they're not finding the traditional slots that they would have otherwise, which snowballs into a great need for direct support professionals for families and for individuals. And so I'm wondering what the department is doing to address that issue, particularly as it really feeds into the need for family members then to take on those support roles and ask for that extra funding and those extra hours. I mean, I think you can see how all of that snowballs and ends up in the place that we're now experiencing. So how is the department trying to deal with that issue?
So this administration, we inherited a lot of structural challenges, to your point, Delegate Guyton, and workforce capacity is one of those challenges that we are actively working through. It's not anything that's germane to the state of Maryland. As you know, the workforce capacity challenges, it's a national issue that all states are grappling with. With the self-directed services delivery model, it is a model that can be complementary to the traditional services model that is actually reinforced by way of our community providers. So what we're doing is looking at the complete infrastructure of all three of our waiver programs to see how we can better support not just individuals and families in their homes by way of the self-directed services model, but also working in tandem with our traditional providers. That's going to take time. Again, this is a national problem that is not germane to Maryland, but we are looking into that, how we can grow provider capacity, how we can address workforce challenges, how we can make the traditional community provider side be much more attractive to individuals who would provide services and supports by way of an agency model, a community provider model. So we are looking at that. We don't have all of the answers today, but this is something critical to continue to sustain our service delivery system here in Maryland.
Thank you for the question and answer. Recognizing Delegate Pam Gazzoni.
Thank you, Madam Chair. I'm going to kind of combine a couple sort of nitty-gritty questions if I could. The first part of it is on the chart you had up about overtime for family member providers, and approval. I just wanted to check because you sort of said that would be used for emergencies and that kind of thing. So I'm assuming that could be retroactively approved after an emergency has happened. They could come back to DDA and say, we needed overtime for these people for this reason. So that's the part A. And then I was curious also, because I'm fairly sure at the beginning of your presentation, Deputy Secretary, you included saying that for people using doing self-directed, that the folks that they're hiring, they are responsible for training those employees. And I just wanted to get some clarity on what that training might look like, because I know that community providers have to have folks that are working for community providers have to do quite a fair amount of training. So I was just curious about what training looks like under direct support, self-directed. Thank you.
Sure, thank you for those questions. So in regard to the first question, when we're talking about looking at paying overtime, there are emergency situations such as snow, right? Where the support provider cannot get to the family in time because of the inclement weather. We do understand those emergency situations and we look at them on a case-by-case basis. So if there is an incident in which the participant must pay their family members overtime, we encourage all participants first to access their emergency backup plan. And if that fails, we will consider a retro overtime request based on the circumstances. It is handled case by case, and it's definitely to support the participants' needs at the time of the event. I hope that answers your first question. And if you could just remind me of your second question, please. My apologies.
No worries,
Second
that's
question
fine.
was about training, Marlena, given
Oh,
the
yeah.
amount of training on the traditional side, training on self-direction.
Yeah, so participants act as the employees. So hiring, firing, training, staff, and so forth. Participants on the self-directed services delivery side also they have a team. And so we encourage participants to create an employee handbook that talks about the very specific things that are required to be successful as serving as the employer of their services. So participants can work with their teams, also work with their FMCS vendor if they have any questions, and also come to us if they have questions about what it would take to train their employees. But they serve in that role as the employer of their services.
If I could just follow up really quickly. So it sounds like there's no required training necessarily.
CPR and first aid are required training for all individuals supporting participants in self-directed services. So at minimum, that's the floor, CPR and first aid.
Thank you.
Absolutely.
Thank you. Recognizing Vice Chair Bonnie Cullison for a question.
Thank you, Madam Chair. So two kinds of questions that follow up on, and I thank the rest of the delegates for asking my other questions. How aware are the families of the cost neutrality requirement of the programs? You know, have they been aware of it? Are they just now becoming aware of it? I mean, so that they put that their services in context. And then the second quick question is, so this concept of a handbook for the folks who are working with them, I think is a really helpful idea. I'm wondering if you have models to give to them that can help, that they can, you know, have like drop-down menus over, these are the kinds of things that my team needs to know for me, just in order to help with what we're hearing is new, you know, documentation burdens, and I'm looking for ways to make those as unburdensome as possible. So those are my questions.
Thank you, Madam Vice Chair. Thank you for those questions. So in regard to your first question, in regard to a family or participants' awareness around cost neutrality, it's likely they do not know. Right. And so again, the department, as a part of going back to the basics and rebuilding our infrastructure, shoring it up, this is a great point that we can include in our meetings when we're talking with all stakeholders. I will tell you that we have a waiver advisory council meeting the 19th of this month, and we're talking about future waiver amendments We've started a waiver amendment subgroup committee. That could be an opportunity that we could leverage to provide additional information to all community partners, and as well as our other platforms. So in regard to families awareness, it's very likely they do not know, but that's a great suggestion that we could include in future communications or trainings with the broader community. In regard to I'm sorry, before I move forward, are you good with that answer?
Yes, that's fine. Thanks.
Okay, and sure, no, and in regard to the employee workbook, the handbook and so forth, the participants, that's exactly why participants have team members, often support brokers serving on that team with participants to help them with understanding, training, counseling, and so forth, as well as working very closely with the FMCS vendor. We can certainly take this suggestion back and see how we can help integrate this into our training series, into our conversations with our fiscal management and counseling services vendors and so forth. It's a great suggestion and we'll certainly take it back.
Thank you very much. I appreciate that.
Absolutely.
Thank you. With permission of Delegate Taveras and Vice Chair Jones, I'm going to cut to Chair Pena-Melnick for some questions she has before the Secretary leaves.
Thank you, and thank you, Chair Shetty. Madam Secretary, I am encouraging, and I know you always do, you and your department, and I'm encouraging the members who have bills, because I hear that there are some bills being worked on, to please meet before session, first week of session, and try to talk about where it's needed, not needed, where you can compromise. I do not want 10 bills, and I don't want any bills if it can be done without a bill. Oftentimes, we don't need a bill. The department can take care of it as well. So with that in mind, I'm encouraging the members and the department to please work together on things that we can work together, okay? You do not want the committee to make the decisions, although we can and we will, Chair Chetty and I. However, I like you to please, as always, make yourselves available and try to work on finding some solutions.
Absolutely. To date, we haven't gotten any outreaches though.
Thank you. I'm encouraging our members because I know some people are working on some bills, okay? Thank you, Chair Chetty.
Thank you, Madam Chair. Thank you, Madam Secretary. Delegate Denny Taveras for a question.
Thank you, Madam Chair. My question is, it seems like there's this, in self-directed services, you've got some people that are just caring for family members or seeking assistance, but what kind of vetting are they being provided to make sure that the people that they're hiring for whatever it is that they need done are qualified or are in line with the requirements demanded by the programs in order to ensure cost neutrality and some of these other issues that you've raised here today. It sounds to me like a lot of people, unless they've been in this for a while, well, at least in the universe I operate in with the population I serve, people who are immigrants have just been doing this, and now they've been told, hey, you may have access or the possibility to services. So this is a new world for them, something that they've been doing for free. Now they are able to maybe have an influx of money to assist and as a supplement to the families. So the question is to them, I think it's going to be all brand new. And so I don't know what's being done in the part of cultural competency and to assist to ensure that there is cultural competence. Proper vetting of the services. being granted.
Well, thank you so much for that question. Basically, what we have in place is the fiscal management and counseling services vendors actually go through an extensive onboarding process where some of that vetting takes place, to your point. So we know that individuals who are providing services to individuals in the self-directed services model must have CPR and first aid. The fiscal management and counseling services vendors also do vetting by way of criminal background checks. They make certain that there isn't a positive criminal history when onboarding the participants' employees. Again, this is also where it's very critical for the participants' team, the participant, again, acting as the employer, to have a team that's very strong in understanding all of the requirements that and what it takes to be an employer. That's a huge role. And so when participants are working with their families, their team members and so forth, it's really, really important for them to build a team that can support them to make certain that their best interests are being met.
And Delegate Taveras, I just want to point out that you're bringing up an important point, especially given the growth in the program and people's understanding of what it means to be an employer of record and their ability to have the team in place to vet people that they're hiring to be appropriate direct service providers. So that is something we are paying close attention to.
And I appreciate that. If I could just come back a little bit on that, it's just that, at least in what I've seen in other states and whatnot, especially with homemade workers, sometimes when we put our family members, those are the easiest to abuse, right? That they are actually not caring for a senior, not, abusing the case just to make money and sit there and watch soap operas. I mean, it's a little crazy, but it happens. And I'm just saying that even when we think of the issue of elderly care, which is separate from this, obviously, that it's the people closest to us that abuse. So I just want to put a red flag, not to say that in this case that's what's going to happen, but I'm just saying that we have to have some proper vetting.
Thank you, Delegate. Thank you, Madam Secretary and Deputy Secretary. Recognizing, I'm so sorry, go back to Chair Pena-Melnick. I think you're on mute, ma'am.
I just want to clarify for the committee, and I think I'll speak for Chair Chetty as well, appropriations, that we value the workers that take care of, of their loved ones, okay? It's a lot of work. It takes a lot to take care of someone that has special needs. Trust me, I feel that we don't even pay them enough for the kind of work that they do. So I just want to clarify it for our committee and for Appropriations Committee as well, okay? In light of what was just said. Thank you.
Yes, fully +1 on that comment. Thank you, Madam Chair. Recognizing Vice Chair of HSS, Dana Jones.
Thank you so much, Chairwoman. And I appreciate the opportunity to hear and speak with everyone today. Everyone else, my inbox is filled and the phone is ringing. As we here in my office try to help so many constituents who are scared, worried. This is obviously an issue that is affecting family members, right? But I am hearing from dear friends from college as well. It's, outside of my district. I'm thankful for this opportunity. And I just need to underscore the true volume of folks reaching out. I'm curious what data is available on the wages earned by people working in self-directed, and do we have any general data on the individuals providing services?
So we have data for both, and we can certainly provide you with the data of the average hourly rate for a person in self-directed services versus the average hourly rate. It's the higher than the hourly rate of a direct service provider on the traditional side. And what was your second question? So the average.
Do you have
the
any general
hourly rate-
data on the individuals, ma'am? Secretary, I apologize. I feel like I have a little bit of a delay. I didn't mean to step on your. The second part was, do you have any like general data on the individuals providing the services?
Like whether they're family members,
Right.
what kind of data?
Are we collecting? Yeah. Do we family? Do we just have any information? Are we tracking that in one way or another so we better understand the issue overall?
Marlena, do you know? I mean, we normally
Yes.
don't. Okay, go ahead, Marlena.
Yes, so by way of the fiscal management and counseling services vendors, we do collect information on the individuals who are providing services and their relationships to the participants, as the participants act as the employers. So for example, we do know that in fiscal year 2024, we closed out at about $143 million that was paid to family members under the self-directed services delivery model. So we definitely are looking at data as we shore up the infrastructure within our 3 Medicaid waiver programs.
Thank you so very much.
Absolutely.
I also want to just add on, if I may, that in response to the FY25 budget that came through our subcommittee, the joint chairman's report included a request to the department to provide a lot of this data. And so I know members of my subcommittee were provided a copy of the responses from the department. So you should have that in your inbox if you would like some additional information, Madam Vice Chair. And I know that we've also provided that we forwarded it as well to the councils on HGO for distribution. So thank you, Madam Secretary, and thank you, Madam Vice Chair. Are there further questions from either committee members? And I also want to just take a moment. I saw that our HSS subcommittee member, Delegate Gabe Acevedo, signed on after I had done introductions. So I wanted to take a moment to recognize him and thank you for joining as well. If I don't see any further questions, so I want to just add a quick thank you and a request to take further dialogue of something offline. But Madam Secretary and Deputy Secretary, thank you for continuing to have ongoing discussions with us and the community providers and the individuals and families, and hearing the concerns that they have raised and some of the confusion in the initial publication. I think that the FAQ document that was provided helped clarify a number of the concerns that my own constituents had raised, that I had spoken with you about. I am hearing continued concern, however, about some conflict or lack of understanding around how some of the new forms may be applicable in the event that like a raise wants to be provided to a current service provider that might exceed the current wage exception amount. And whether specifically the requirement to post the job and seek 5 applicants and do all of that is a requirement as well, given that there's conflicting regulation from the Department of Labor around whether you can post a job that is currently filled. So just wanted to pose that as a question that constituents have asked. And if we need to take that conversation offline, I would welcome that further dialogue. But for the committee's purposes, sorry, one other question I just want to make sure I ask is there has been ongoing reference to audits, both by the legislative audit committees as well as CMS. And so I just wanted to ask if the department can share specific So I know policy recommendations have been made that you all are responding to, but have there been specific dollar amounts that have been flagged as improper reimbursements in the program that were provided under the past rules? And if so, are you able to share with us that amount? As a subcommittee chair with that budget, I'm very keenly aware of what we are getting ready to face when we come back into session.
So for
Thank-
the first issue, it would be helpful if they came to us so we can have that discussion directly with the member, the participant, because those issues have to be worked out on a case-by-case basis. So for a participant to go to you before they come to the department, it's hard to reconcile those issues, and we don't get a chance to speak to the participant to understand the issues. So that's one. On the second issue, the OLA audits are very public, so we can share those. We've had repeat findings on a few of them, so we can make those OLA audits public. And on the CMS audit, we'll provide those. They're old. There's one outstanding finding, but we can make those available as well.
Thank you, Madam Secretary. Chair Peña-Melnyk?
Just want to say thank you, Madam Secretary, for being with us today. We really appreciate it, and for leaving your team on the call so that they can listen to the rest of the witnesses as well. I know that these are very challenging times that we are going to, as the chair just stated, be facing and are facing. And I just hope that we can have, as was requested, some type of handout with the rules, knowing that rules change, right? And times change, but at least some type of handout that people can be given, that you can also post on your website, and that it can be given to every new person that signs up for the services as well. Perhaps the department can also think about some different trainings as well that it can develop, and to do it constantly, periodically, just to reinforce it to people of what's expected. I look forward to working with you. As always, I enjoy working with your team. Our committees, both appropriations, and I'll speak for Delegate Shetty and Chair Barnes, and our committee here, we're open and willing to work with both the community and the department as well. I hope you have a blessed day and have a great meeting.
Thank you so much. Sarah will take my place here. Assistant Secretary Hutchinson will serve, Deputy Secretary Hutchinson will stay on the phone. And for those of you, enjoy the holidays, and sorry to leave early. Thank you.
It's all right. Thank you. Enjoy the holidays. Chair Shetty, thank you so much for your leadership. And I am now going on to the financial management and counseling services providers. And we have two people, Matt Morgan and Kirsten Capeless. I'm going to start with Mr. Morgan. The way it's going to work is that you will both speak, and then, as Chair Shetty did, we will open it up for the members to ask their questions. Again, the tone it has to be respectful and humane. Okay, so let's go on with Mr. Morgan, and not our Matt Morgan.
Yes, thank you.
Go ahead.
Good afternoon, Chairwoman Peña-Melnyk and Shetty, and members of the Health and Government Operations Committee. My name is Matt Morgan, and I'm the Chief Program Officer at the ARC Central Chesapeake Region. I will commonly refer to our organization as the ARC throughout my comments to shorten the reference. It is worth noting that there is also an ARC Maryland, as well as 9 other regional ARC chapters in Maryland, although we were all separate entities. Thank you for providing the opportunity to participate in the briefing this afternoon. In my role, I oversee the ARC's services, including self-directed services, as well as traditional provider-facilitated services, such as living options and services, workforce development, day services, children, youth, and their families programs, and behavioral health services. I've worked at the ARC for 6 years and have been working in the developmental disabilities field in Maryland for over 20 years. Today, the ARC supports over 4,000 people with intellectual and developmental disabilities and employs over 600 people in Anne Arundel County and Maryland's Eastern Shores. Our mission goes beyond daily services. We focus on creating equitable, accessible, and fully inclusive communities within our organization. We have been a partner with the state in providing FMS services for over 19 years. We are the largest fiscal management and counseling services provider in Maryland, supporting over 2,900 people who self-direct their services. The ARC began providing fiscal management services for people who self-direct in 2005. At that time, the ARC was one of only 2 FMS providers in the state, and there was a separate waiver program for people who self-direct their services. For many years, there were only a few hundred people in the program. Fiscal management services, now FMCS, consist of supporting people who self-direct their services to become an employer of record, verifying qualifications of their employees, ensuring appropriate tax forms are filed, and processing payroll for the employees of participants, as well as payments to their vendors, among other functions. Until 2022, when DDA implemented the new contracts with 3 FMCS agencies pursuant to the RFP, the system was very analog, meaning the vast majority of participants' employees submitted paper timesheets and participants received monthly statements of expenditures via email. Attempts to change this prior to the new contract were often met with resistance. With the transition to the new FMCS model, staff of participants were required to begin using electronic timekeeping software and could track their budget usage closer to real time. This was a significant change for many participants, and the ARC worked with DDA to allow some flexibilities to continue, such as continuing to process paper timesheets for some people for several months past the original deadline. The transition over the past 2 years has not been easy for anyone involved, but the ARC has been supportive of the goal of modernizing this model of services to ensure it is successful for years to come. With the release of updated guidance from DDA in October 2024, the ARC has been working to ensure we have the resources internally to meet any changes in procedures or additional requirements, just as we have done over the past 2.5 years. We appreciate the time to share our work and service to the state. The ARC remains a committed partner in providing efficient, streamlined services and supports to people with intellectual and developmental disabilities. We are happy to collaborate with the department and legislature on processes and procedures to enhance services and support. I'm happy to answer any questions, or please feel free to reach out to me in my office for any follow-up or questions. Thank you.
Thank you. We're going to go on to Kirsten Capeless, please.
Thank you so much. Madam Chair Pena Melnick, Madam Chair Shetty, and members of the committees. My name is Kirsten Capeless, and I am the National Director of Business Development for GT Independence. Thank you for inviting me on behalf of GT Independence to speak to our services within the state of Maryland. I have had the pleasure of working to set up and providing services within our Maryland market since receiving the award for the Financial Management and Counseling Services contract, which began in February of 2022. I'm here today to discuss the history and services of GT Independence, the services within the Maryland market administered by the Developmental Disability Administration, and also answer your questions that you may have. As one of the first organizations to provide financial management services nationally for the self-determination programs, GT Independence has been instrumental in shaping the national FMS landscape, establishing itself as a leader that delivers comprehensive services to state agencies, program participants, and their employees. The core values of self-determination, professionalism, integrity, community, excellence, and respect are at the foundation of everything our company does. This commitment to its values has enabled GT to grow to deliver FMS in 17 states in the District of Columbia, including Maryland. GT's services offerings include core features of customer service, enrollment, payroll, billing, tax and accounting, reporting, and quality control and compliance, all provided within the context of a person-centered, values-driven approach. GT's services are further enhanced and differentiated by the company's state-of-the-art technology. GT's in-house engineering team builds and supports our company's industry-leading platforms, which include the Electronic Visit Verification or EVV compliant GT app, our web-based portal, our caregiver link to assist participants in finding employees, and our payroll system. GT sets itself apart as the foremost choice for FMS by combining an unmatched commitment to quality, security, and service, as demonstrated by our unique credentials, including CARF accreditation, high trust certification, and SOC 2 compliance. This powerful combination, held by no other FMS provider in the industry, underscores our rigorous dedication to best-in-class standards across all aspects of our operations, elevating the level of support we deliver to clients and participants alike. Our CARF accreditation reflects our unwavering commitment to service excellence and quality assurance, reinforcing GT's reputation as a trusted partner in FMS. High trust certification strengthens our adherence to high security standards, safeguarding sensitive information and upholding participants' privacy, at every level. SOC 2 compliance further solidifies our focus on data integrity and operational transparency, giving program partners full confidence in GT's ability to uphold rigorous accountability. Together, these credentials uniquely position the company as the FMS provider that sets a benchmark for the entire industry. Moreover, GT's innovative staffing algorithm ensures that key performance indicators are consistently met across every facet of our service, including participant onboarding, customer support, and response times. This algorithm-driven approach not only elevates our standard of customer service, but also guarantees that we achieve and often exceed the stringent performance criteria by the DDA. By matching staffing resources with program needs in real time, GT delivers a highly responsive, proactive approach that addresses participants' and caregivers' needs effectively and efficiently. GT's commitment to quality, security, and personalized service standards unrivaled in the industry. Our distinctive combination of credentials, operational innovation, and performance accountability gives program partners the participants complete confidence in our ability to deliver a high-quality, dependable, and supportive experience. So I want to dive into the services in Maryland, as well as the recent policy changes you asked for us to come speak about. GT is committed to advocating for self-directed services throughout the country. GT feels everyone should live the life of their choosing and have access to self-directed services. Currently, there are 269 HCBS waiver programs in the United States. Of that, only half include an option for people to self-direct their care. In Maryland, the DDA administers 3 waivers, all of which offer self-directed services. Within the FMCS contract, there are 2 additional programs that will offer self-directed services administered under the Office of Long-Term Services and Supports, or OLTSS. These programs have been in discussion and will hopefully implement in the near future. In addition to this, GT is hopeful that self-direction will continue to be expanded within the state to include state-planned personal care and other federal funds, such as Title III block grant funds. GT is proud to bring the company's services to Maryland DDA programs. GT values a collaborative relationship with the DDA, participants and their employees and vendors, advocates, and along with other key stakeholders such as yourselves. In particular, GT is glad to see the DDA issuing a succinct policy manual. This was a request made within a stakeholder group held in late 2023 after the DDA had issued a number of separate pieces of guidance. As an FMCS within the market, it is tremendously helpful to have a source document that guides practice for our operational and business purposes. This transparency aids in understanding and communication between all of the stakeholders within the Maryland market. GT is also glad to know that the DDA is committed to moving towards electronic authorizations. GT has engaged in active conversations with the DDA and other stakeholders in joint DDA facilitated meetings over the duration of our contract in Maryland. This enhancement will bring Maryland in line with many other states that we are serving nationally. By providing electronic authorization, GT and the other FMCS organizations will be able to process budgets and budget modifications more expeditiously. GT is engaged with the DDA in conversation about the new policy manual related to vendor expectations. In Maryland, participants can self-direct their services and directly hire and manage employees to meet their needs outlined in their person-centered plan. In addition, participants can contract with vendors in order to access individual directed goods and services, commonly called IDGS. At a high level, goods and services are required to meet a participant's defined need and also reduce the need for other Medicaid services. Goods often include discreetly purchased items, such as a small kitchen appliance like an air fryer that allows a person to cook independently and therefore not need a staff to cook for them. Services include services delivered that directly meet a specific need of the participant. Oftentimes, within waiver authorities, self-directed services are available through direct hiring of staff, and IDGS is available for procurement of allowable items that do not fall within these services. This provides participants access to services that are delivered by a vendor that typically does not enroll in Medicaid as a service provider, such as housekeeping, lawn care, snow removal, Walmart, and other common purchasing locations. By having a service available through one pathway, it streams the service and governs it under one clear set of rules. In Maryland, some services have two paths of access, such as personal supports and community development services. These services can be delivered by an employee that is directly hired by a participant and can also be accessed through IDGS by hiring a vendor with their own staff that deliver this service. You may wonder why this matters. When a participant hires an employee directly to deliver a service, the FMCS confirms that the employee meets criteria to perform this service. The employee also uses the FMCS's EBV system to document their time worked. When a participant hires a vendor, the vendor company itself hires the employees, confirms that they qualify for the service being delivered, schedules and performs the services, and then invoices for the service. This vendor also keeps track of the hours their employees worked within the vendor system, along with the other criteria that relate to qualifications to perform that service. There's a risk to a system if a vendor hires and allows an employee to perform a service, but that employee does not meet the basic requirements of the service delivery. This risk is mitigated during a direct hire, since that employee has to meet the basic requirements before they can begin work. When a vendor is used, the FMCS is receiving the invoice after the service has been completed. If it's found that an employee did not meet the basic requirements, then a payment cannot be issued for reimbursement. This can lead to frustrations for the participant and their vendor. As I mentioned a moment ago, typically individual directed goods and services are used for one-time purchases which fall within goods and services that are not Medicaid delivered services. For example, a person may hire a housekeeper which provides a service that is not funded within Medicaid services, but reduces the need for a Medicaid service such as personal supports, which can also provide instrumental activities of daily living or IADLs, like caring for a house. There are not any basic requirements for these types of services as they're commonly purchased publicly available services. For those states that allow vendors to provide routine and ongoing services, such as personal supports or community development services, the credentialing process of verifying that vendors' employees meet the requirements and timekeeping requirements typically fall within the scope of that particular vendor. Typically, a vendor would attest to the fact that their selected employees meet the basic requirements for the state, would then assure this vendor meets the requirements through a license to do business or a direct audit with that particular vendor, which ensures quality of services are delivered within the scope and allowability of services. In addition, some states utilize a separate vendor to perform credentialing services. GT has experience administering credentialing contracts within our other state markets where GT performs this type of service with a separate contract, making the credentialing available to participants and vendors. CS to provide timekeeping and credentialing for vendor employees. It creates a time-intensive process that runs the risk of slowing down payments of vendors. To adhere to this requirement, GT will be requiring vendors to submit confirmation for all of their employees' qualifications with each submitted invoice. This is the most efficient way to handle processing invoices for vendor reimbursements while also trying to address the extra work involved with verifying credentials for each vendor employee that worked within the invoiced period of time. In addition to requiring the verification of vendor employee qualifications, the DDA policy manual requires the vendor to use EBV compliant timekeeping. Currently, the DDA has suspended the requirement for vendor employees to submit EVV compliant timekeeping through the FMCS EVV system. GT thanks the DDA for this delay in implementation while they assess and create a balanced approach to address this data collection. To solve both of these needs, GT is willing to work with the DDA to create and manage a vendor credentialing service and vendor EVV system for all vendors served within the DDA self-directed programs, regardless of the FMCS serving the participant, under a separate statement of work. GT commends the DDA for adding clarification that empowers the participant's role within self-direction. For example, the DDA has clarified that the participant needs to be present when discussing budgetary decisions and is also directly responsible and empowered to sign off their employees' timesheets and vendor invoices. This is the very philosophy behind self-determination. If the participant needs or desires assistance with these employer duties, they are able to select a legal representative, which in turn would take on these roles and responsibilities. In conclusion, GT is honored to serve the participants of Maryland, the DDA, and other key stakeholders as we deliver financial management and counseling services. GT values working side by side with the DDA to deliver a system of services that meets the participants and key stakeholders' needs in Maryland. In addition, GT encourages Maryland to consider expanding self-direction to other service platforms, such as the OLTSS and state plan services, to best meet the needs of all Marylanders and allow all participants to have access to living the life of their choosing. GT is grateful for this opportunity to discuss this important service, and I'm happy to answer any questions any of the members of the committees may have. Thank you.
Thank you. I appreciate you. That was a lot, but it was necessary to understand the whole system. I think it's becoming clear how it works. I'm going to open it up for questions now. And I see first Delegate Hill. Delegate Hill, please unmute yourself. Thank you.
Thank you, Madam Chair. I want to
My
thank
pleasure.
both of our presenters just now and apologize for being late to the earlier presentation. I'm going to direct this to Ms. Kaflis. Do you have any projections, numbers, or idea of the cost of these additional services to the patient, and does that money come out of their reimbursement? So, so we have a certain fixed amount of money that they're getting for the care. They're choosing self-directed care. They're needing to hire additional vendors to provide it, including, because of the electronic requirements, some additional things into what they're doing now. You all get paid through that same pot of money, or how does that work? And if it's through the same pot of money, how much does that siphon off of what they could then be providing to the people providing the care?
Thank you for your question. I appreciate it. The FMCS organizations are paid by a per member per month fee that does become part of the participant's budget. That's in addition to the pass-through costs that go to cover the employer portion of the employee's wages, as well as the actual cost of wages and the cost of individual directed goods and services. So that all comes together under their plan of care and stays within that umbrella of cost neutrality. So cost neutrality is not unique to Maryland. It's a requirement by CMS to say the same level of institutional cost is achieved out in the community. Now, when you start to compare self-directed services to traditional agency-based services, oftentimes what you'll find is the employee delivering the care is able to be paid higher. Because of the rate of the PMPM that the FMCS receives is less than the cost of the overall overhead that the agency needs to run its business. And therefore, the actual employee delivering services receives more dollars because the participant has that flexibility to make those choices. That's really fantastic when you think about workforce stability and the ability to hire and maintain consistent, lasting staff. So as you know, training and hiring staff is a hugely expensive process. So if you're able to hire people you trust and keep them a long time to deliver that most important care, you not only get the right care at the community level, you also avoid things like unnecessary institutionalization when somebody doesn't really need that level of care. I hope that answers your question. It was a little longer than you
No,
had
no, no,
asked.
no, that's fine. Just a quick follow-up. When you say that that the employee is often paid higher, does that take into account any additional costs they may have because they haven't had deductions taken out by an employer, so, or their benefits and all that? Does that mean all benefits covered, they may be making more, or is it a net zero, or is it slightly less when you put in all the benefits they would get if they were managed through an agency?
Excellent question. There's a lot of different ways to look at the full cost analysis. So it is a net zero when you look at the total budget to the total budget, right? So you always have to have that net zero cost neutrality. When I was referring to higher wages, I meant through their hourly wage. When the FMCS processes an employee's wage, the taxes are taken out. So that in Maryland is applied through a stipulated rate. So they'll have their wage, they'll have the stipulated rate that covers that employer burden. If a participant chooses to offer benefits or for those areas in Maryland where, for instance, sick and safe leave is required, that's also already factored into the budget. So it really is an apples to apples comparison.
Thank you so much for your patience as we ask these questions. Chair Shetty.
Thank you, Madam Chair. And thank you to Ms. Capeless and Mr. Morgan for providing your testimony today. One of the ongoing concerns that I've heard from constituents, both on the participant side as well as the vendor side, not vendor, but like the DSP provider side, is that it is taking a very long time to process payments and reimbursements. And I know that there was a period of time in which the system wasn't fully operational across the entire state, which caused a bit of a logjam. I'm wondering if you can share with us an update on how things are going in terms of returning back to a place where payments are being processed within a specific time. And if you have anything, like if you have a standard time frame that you seek to adhere to, what percentage of payments are able to be reimbursed within that period of time? Thank you.
I guess I can go first. We, in terms of vendor payments, there have been times where we've fallen behind, but generally we pay on a cycle, and we have a payroll, an accounts payable schedule published on our website. At this point, again, we with the influx recently of new people into services, with the transition youth coming out of school, we've been bringing on about 150 participants a month. And DDA had sent a memo out to participants to anticipate delays with onboarding. We have fortunately not. We've been able to adhere to our onboarding goals for participants. With some vendor payments, we slipped behind, but only briefly. We've been issuing 2 and 3 payments a week, as opposed to 1 payment a week. And so as of the end of this week, we anticipate being fully on schedule with that. And when we do fall behind, it's often several days or a week. It's not typically that long. I will say that there's often misunderstanding amongst vendors in terms of they'll come to us asking for payment, but the process is that they send their invoice to the participant to sign and complete a vendor payment request and send to us. And so we've often not received invoices at all, or they don't have the complete information or whatever. So it's like we communicate that back to the teams in those cases, but there's misunderstanding amongst the vendors. The vendors come to us seeking payment, not realizing there's sort of a third party in there that they should be going to for payment. And I think that the new guidance makes it clearer to people to first start with the participant as the core of everything, who should be forwarding that along, and ask them to follow up on the payment to make sure that we're not getting unnecessary communication about payments that we've not even received an invoice to process for.
Thank you as well for that question. I agree with what Matt said. So With standard payments, we have a payroll cycle that's published. Actually, all 3 FMCSs have standardized our payroll cycles, so that way we're collecting time during the same period of time and we're issuing pay at the same time. That helps in case somebody does want to transition between vendors. It makes it very seamless. You don't have to worry about hiccups in payroll schedules that impact pay. So we should all be issuing routine pay on time. Now, there's always caveats to why pay may be delayed, and it's often because a person may not have all of the eligibility requirements met. So for instance, if a participant has an employee and that employee's CPR or first aid expire, then they no longer are qualifying for delivering the service. The participant is able to see that inside a GT system as well as the employee because those certificate dates are loaded in our system. In addition, we do courtesy items. Like for instance, yesterday we just sent out 30-day notices to anybody that is within 30 days of having their CPR first aid expire. So that way they can proactively address that. Sometimes somebody may sign up for a course that doesn't qualify. They may do an online course and you have to have a hybrid in-person component in order to meet the Maryland requirements. So that might impact pay, but has nothing to do with our ability to issue pay, but has everything to do with the eligibility requirements in order for us to have the authority to issue pay. In addition to Matt's point, there was a big shift inside of Maryland for the participant to be the employer of record and the controller of their funds, which is appropriate and expected within self-directed services. So that participant does need to sign off on the invoices. This allows us, the FMCS, to know the participant approves those charges. If you don't have their signature, you have no way of confirming that they actually authorized those charges to be purchased and delivered, nor do you know if the service actually occurred. So it's a really important safety mechanism that's in place to make sure budgets are expended as you would expect. That's a newer process, but a really, really good one that the DDA put in place. So sometimes we might get an invoice from a support broker on behalf of a participant or from a vendor directly where they want reimbursement, but we have to pause and then collect the signature and then go back and process it. So it may feel like a delay to payment, but in actuality, it's us following the appropriate measures to ensure payment is made only when appropriate. I hope that helps answer your question.
Thank you. Thank you for answering the questions. Delegate Guide.
Thank you so much. I've had a couple of concerns about a new regulation, and I know it's related to self-direction and the importance of the participants' involvement in that. But I have been told that now it is required that the participant actually be on the telephone when anyone is calling the financial management services regarding that account. And I want to know how you are actually making accommodations for those participants who are nonverbal or who have behavioral issues and don't want to participate in that, or who have really complex medical needs, because I've heard that this has been an issue for some families. And I'd just like to hear your response to that.
I guess
One
I'll go.
second. Who's the best person to answer that question? You want to go ahead, Matt?
Sure. I mean, it would be either of us. I think we've heard the same concerns. The state has assured us that we don't, if we ask if someone is on the telephone, if the participant is on the phone with the person who's calling, that their assurance is all we need. We don't have to go beyond that in terms of putting the person on the phone or something like that. I think we've only been asked to monitor to see if any particular people communicating us have a trend of where that could potentially not be the case, where we feel like they say that often and we've never heard from any of the participants or something like that. But other than that, it doesn't, I mean, there's no other way for us to operationalize that other than to just ask if the person is present and take their word for it at this point.
If I may add, I think in particular, this goes to the guidance that when a support broker is performing their duties, they do so in alignment with the participant rather than in place or on behalf of the participant. That truly is the general model of support broker services, where it should kind of be side by side and not in place of. You will always want the participant to be executing the decision-making authority and not giving that to the support broker who's a paid vendor. So there's a general conflict of interest that occurs when somebody that's being paid is also executing decisions on behalf of the participant. So there could be a participant or a legal representative that is assisting the participant in navigating those choices and decisions, but it should really own that ownership and empowerment of those decisions. I don't know if, respectfully, if the DDA may at a different point want to address this piece as well, since it is their policy measure.
Thank you so much for answering that. It is a really complicated new regulation. Thank you.
I know Delegate Jamila Woods just texted me. She has a question. She says, I'm interested in the inclusion of mental health first aid if it has been considered. And if you ever, oh, Matt?
That would be a question for the department, I believe.
Okay, all right.
Want to make certain,
1 second, please. 1 minute. Because you're not on, we already had you as a panel, so we have to have order. So let us go through the witnesses, okay? Are there any other questions? Delegate Bagnall.
Thank you, Madam Chair, and thank you for being here today and presenting. This question I think is for Ms. Capeless, because I know that GT Independence was very active in the self-directed services legislation and in bringing self-directed services not just to Maryland, but I think you started in Michigan and have been specifically lauding self-direction. So I'm just wondering if our vetting process for vendors is somehow different than other participating states, because it seems as though some of the issues that we have encountered, I know GT, had some vendors that weren't that were not meeting the minimum requirements, and we've been working to get them up to compliant. But is this something that we've experienced in other states, and is our vetting process somehow different, that we had such a disparate compliance issue?
Thank you so much for that question. I think every state has uniqueness in their various approaches to services. So I think in a Medicaid world, you say if you've seen one Medicaid program, you've seen one Medicaid program, right? And I know we can all chuckle over that, especially in this type of setting. That being said, I think there are some differences that the DDA has put into place that have been very positive, and helping to align the authority of the participant is definitely one of them. And as such, that changed some of the approach to the vendoring process. In particular, previous to this contract, I believe this supports broker played a more primary role, functioning in some ways as the employer, not necessarily on paper, but in execution of the duties. And inside of this more current contract that started in 2022, DDA has taken a stronger approach to kind of right lane each of those authorities from our perspective. So we actually commend the hard work that it is to make those systems changes. So some of what you're hearing, I think, is those realities of helping the employer of record, the participant, be the truest authority over their budget and their services. What that means on the ground is simple things like all the invoices have to be signed by the participants. So if you're in a system and been working in a system for a really long time and never had to take that step or didn't take it on routine basis and now you have to, that just is a change in practice that everybody needs to get used to. In Maryland, there's a lot of vendors, and so that means a lot of different people were impacted as things got kind of more centralized and streamlined. I think that the policy manual and the pieces that DDA have put into place are great steps in that direction. One caveat I'd like to offer, which is what I provided in my written and spoken testimony, is the credentialing related to the vendors. So typically speaking, a vendor is going to submit an invoice, and it's going to be somebody that's not producing or delivering a routine service available already inside of the waiver or another Medicaid paid service. So for instance, you might have a vendor that's a YMCA, right? And somebody wants to participate in the Y services, and the Y is not going to enroll in Medicaid and deliver a service. So you have an entity like ourselves that helps be the conduit and access for those payments and reimbursements related to those approved services. When you allow a service provider to deliver services like personal supports or community supports, but they're also another part of the waiver, there's extra layers of qualifications that need to be vetted, and that's okay, and that's actually good. When states do that, typically though, they usually either have a business licensing process that vets that vendor as a qualified provider, or they have a credentialing contract. So GT does fulfill credentialing contracts in other states where we as an entity outside of our FMCS role would vet that the vendor qualifies, double check that their staff meet all the criteria, and then kind of sign off on that vendor. That makes it much more fluid and quickly to process payments. So I would say that's one of the caveats that's different in addition to how timekeeping is collected. Again, if an employee directly hires an employee, an employer hires an employee, excuse me, they use our system for EVV data collection. If a vendor has a team of employees that deliver a quarter-hour EVV required service, they should be using their own system or sometimes even a state generic system to collect that. But typically, it's not the FMCS's EVV system because they're not set up as employees in our system. They're set up as vendors and wouldn't have access to that component. Also, the employer is the vendor, and they don't have access to sign off on time in our system, right? The participant is only one that has access. So it's just like one step removed, so to speak. So that's part of what I said in our written and spoken testimony. We're willing to partner with the state should it be of the department's interest to offer that across the vendor structure, not unique to the ones that we serve, but more holistically to partner for a solution. That being said, there's other avenues should they choose a different path for a solution as well.
Thank you. Thank you very much for your answer.
You're welcome.
Thank you. So I'm going to do something that I usually do not do, but I think it's best to clarify things. So Deputy Secretary Hutchinson, will you be so kind and address the questions that were actually given to these two witnesses, and they are actually department questions, if you're able.
Thank you, Madam Chair.
My pleasure. And thank you for your patience, okay?
Oh, absolutely. If the question could be repeated, please.
I was Delegate Guyton. You had the question, very specific, please.
Thank you. My question was about accommodations for participants who are supposed to be on the phone line with their support brokers and their financial management teams, but are nonverbal or have behavioral issues and don't want to participate. How are they being accommodated for? Parents are very afraid then that they won't be approved.
Thank you, Delegate Guyton. So as Matt had mentioned in his testimony, the department is making certain that those accommodations are readily available if the participant, this is a participant-driven process. And so if the participant elects not to participate in that process, we have supported our FMCS vendors to just make certain that as best as possible, we can accommodate those requests. We are very much interested in understanding that the participant's choice is always at play and not someone else's. So as Matt said, we ask if the participant is available, that is our preference. If not, then we go forward with the transaction, the engagement. If we note that the participant is often not available, then we reach out to the CCS as well to just make certain that this is a participant-driven process. So we're handling these things on a case-by-case basis, always making certain that the participant is first.
Thank you for that. I'm not sure it's consistently being employed that way, but I appreciate that answer.
Okay, and if you can make sure that you can review some of the cases, Deputy Hutchinson, and make sure that it is consistently applied if there are some problems, okay? I'm not making assumptions, but if just look into it, please. And then Delegate Woods had a question. She says, I'm interested in if the inclusion of mental health first aid has been considered. I believe that's your question to answer. Deputy Hutchinson.
So in regard to mental health first aid, we do have what we call dual diagnosis services provided to participants. In regard to the first aid component, I would like some clarification just to make certain that I'm answering exactly what the delegate is interested in understanding.
Delegate Woods, will you be so kind? I know it's a little loud where you are, but we'll deal with it. Can you clarify your question, please?
Yes, in the same way that you talk about the CPR certification, I want to know if you are taking into consideration the mental health certification.
Thank you. Are you able to answer that question, Deputy Hutchinson?
So is she requesting if we are taking into consideration mental health services for employees?
The certification program in the same way that you have the CPR certification requirement.
So what
So-
she's saying is just like you have the CPR requirement, right, for the employees?
Yes.
But do you do any training regarding mental health for the employees?
We can certainly look into that, take it back and look into that.
So
Currently,
because the
no
mental health first
right.
aid certification is a nationally recognized certification, just as CPR is.
Under our current model, we just have the CPR and first aid certification training. We can certainly take the delegate's question into the suggestion into consideration.
Thank you. And she states that it's a national model recognized. So if you could, Delegate Woods, you don't need to unmute yourself. Will you be so kind and send Deputy Hutchinson and the secretary the information on the program, please? Thank you. And thank you, Deputy Hutchinson, for answering the questions. Any other questions for these panelists? All right, seeing none, let's just check in for a minute. It is 2:47. My hope is to have finished by 3, but I know that this is a very important issue. And I really think that we need to be flexible, given the population, given the emotions and everything else that's happening, right? With the same respect and humanity as well. Let's just be a little bit generous today. So the next panel is the support brokers, and my colleague, Chair Chetty, will take that one. Thank you, everyone, again for your patience. Chair Chetty.
Thank you, Madam Chair. For our support broker panel, we have one participant, Irene Suwada. Forgive me for the pronunciation if I've misstated it.
Great.
Maryland support broker with Choice and Control, Inc.
Right. Yeah, so good afternoon. I want to thank everyone here today for your commitment to Marylanders with developmental disabilities and their support teams. My name is Irene Swada. I am the CEO of Choice and Control, a support broker provider. I have been an active, wrong presentation. Thank you. I'll wait. Maybe it's better for the right presentation.
Please wait 1 second.
Thank you.
Staff has worked really hard to put this together, and I want to thank staff, both from
Oh,
HGO
yeah.
and appropriations. Thank you for doing this work. It's a lot of work. Go ahead.
And I'm really appreciative. I'm like, did they mean to call me? But I'm really glad I'm here. So thank you. Okay, wonderful. So we'll start here. So again, thank you everyone for being here today, especially everyone that's tuning in on YouTube as well. So again, my name is Irene Swada, and I'm the CEO of Choice of Control, Inc., a support broker provider. I have been an active support broker for more than 10 years. Prior to that, I was a CCS supervisor for 11 years. I've served many roles over the last 3 decades, supporting people with disabilities from childhood to retirement age. I began my career as a direct service professional and gained valuable experiences of the challenges people face as a parent of a child born with a rare genetic disorder. I currently serve in the Department of Disabilities Commission, the Maryland Equity Coalition for People with Disabilities, and co-organize La Vida Buena, a mutual aid program for the Latinx disability community. My personal mission has always been to build an equitable society. I am here today to speak on behalf of Maryland support brokers who share the same mission. Next, please. My apologies. Okay, so the first impact that I want to share is how the policy updates undermine the principles of self-directed services. The circle of support begins with the person. We as members of the team are here to support the person to achieve a healthier and meaningful life as they envision for themselves. Neither DDA nor the Department of Health work directly for or with the employers, yet released a manual with no consultation. The manual serves to act as an informational guide to people receiving services, yet they cannot access it. DDA and the Department of Health scrutinize the other team members, such as family members and support brokers, but are so far removed from the employers that they could not know what best practice truly is without actually talking with everyone. Next slide, please. Okay, excellent. So the Maryland Department of Health's recent policy updates have been met with confusion, fear, and anger among employers and their teams. A person who chooses the self-directed model has choice and control over who, what, where, and when they receive their needed services and supports. A policy manual was needed, yes. However, it was not written or disseminated in a way that was meant for people with disabilities with intellectual, visual, and/or processing disabilities to understand and implement. This policy was shared on October 24th with an implementation date of November 21st. That is less than a month during a time when most people are traveling and preparing for a national holiday. It was recalled once because of a misunderstanding on how protected savings accounts could not be used against people with limited resources. There are specific employer-related mandates that the employers were not able to adapt to before implementation. In addition, I notified DDA and the FMCS agency that reducing an employee's rate without notifying the employee at least one pay period in advance is a violation of Maryland's Department of Labor Fair Wages Law. Broken labor laws, inaccessibility, and decisions that do not represent the interest of the people all hinder the person's ability to be the employer of record. The second impact is how exploitative and discriminatory practices have now become the norm. Next slide, please. There has been little evidence, and forgive me, because I know we have a brief amount of time, so I have to be direct.
Yes,
There
because
has
the
been little
traffic on
evidence.
Georgetown, they've closed down
I
a lane on both sides. So
Are we able to?
Vice Chair Cullinan, can you please mute yourself? Thank you. My apologies.
There has been little evidence showing that the Maryland Department of Health is eliminating disparities in access to waiverable services. As a result, team members have had to take on undefined roles to meet the needs of the employers. Support brokers wear many hats to ensure the person is able to maintain their employer and budget authority. We are interpreters. Choice and Control is a diverse team of Latina, African, neurodivergent brokers and staff. Our cultural and linguistic knowledge helps us to develop relationships with and resources for a diverse group of employers. We're advocates. The role of the support broker at its core is an advocate. There are parties involved denying necessary and life-saving services, and we work with the people we serve to make sure they get what they need. We're trainers. CCSs are not receiving timely and adequate training. When so much of our employers' services are pushed onto the CCS, who can't turn to their supervisors for lack of training, they turn to others who have insights, such as experienced support brokers. We're confidants. I ask employers when I start with them why they chose self-directions. It brings me to tears to hear stories of abuse, rape, and neglect that have happened in the care of licensed providers, schools, and nursing homes. People living in their community struggle with many of the same issues, such as alcohol and substance abuse, domestic violence, housing, and food insecurities. Employers trust us with this information so we can better support them and are not comfortable sharing with this with a coordinator who will add their private information into LTSS and leave in a few months. All of these roles are crucial, and when no one else will step up, we do, because we work at the direction of the person. However, these roles were not taken into consideration when DDA made the decision to limit our ability to share our expertise around available resources so that people can make informed decisions. Next slide, please. At Choice and Control, we make a concerted effort to serve people from underserved, marginalized communities. Our customers represent at least 15 countries, and many are first and second generation immigrants. They are Latinos, Africans, and Asian immigrants with disabilities seeking services that have limited access. A vast majority of resources and communications are only offered in English. DDA has been informed on multiple occasions that implementing a new manual in only one language and format is essentially, and forgive me, discrimination, putting people at risk of committed accidental fraud because they did not have access to the manual and other resources. DDA's history of this has instilled a fear of retaliation in these communities. Employers have also requested that the manual be released in other formats accessible to those with different disabilities. I want to take this moment to point out that in Appendix B8 of the Community Pathways Waiver, it says that the state will, and in quotes, provide meaningful language access to individuals with limited English proficiency who are applying for or receiving Medicaid services, end quote. The waiver states that interpreters will be provided at no cost to the person and would be making available language translations of various forms and documents. This has not been enforced, and DDA has denied access to other resources such as ESL. We cannot assure that no Marylander is left behind if we can't give them the information in a way that they can understand and follow. This is a misconception that the majority of people who are self-directing are exploited by their family members for their financial gain. Among the 120 people that we serve, the majority of employers have a mix of non-family and family employees. There are also large numbers of people who have no family as staff at all. Self-directions have given employees opportunities to make a living wage, reducing the need to work 2 or 3 jobs and spending more time with their families. I have had the privilege of seeing direct service providers buy their first homes, get reliable cars. I'm sorry, next slide, please. And live a better quality of life. Under self-directed services, they're able to work full-time, receive health benefits, and pay time off like any other place of employment. Another misconception is that other team members are speaking for people with disabilities. Our job as support brokers is to ensure there are no conflicts of interest and the person's needs are at the forefront. Even so, most of the people we support are more comfortable having a trusted person to be present during phone calls and meetings. It is no different than you or I wanting a trusted person by our side when making a difficult life decision. Many of the people we support have social anxieties and are still building their confidence and expressive language. They need to hear from us that we are listening in order for them to want to speak. In the meantime, we continue to work with our allies and to ensure their voices are heard if that is what the employer wants. Next slide, please. The third impact is how the lack of training, competency, and availability leaves people with limited choices. Next slide, please. The more we chip away at the circles of support between the individual and the state government, the more we make people dependent on an already overwhelmed social service system. The CCS, DDA, and FMCS are all required parts of the employer's team, yet often pose the most obstacles. There is no accountability for FMCS, at least not from our point of view, or DDA to the employers. DDA has repeatedly dismissed concerns from the people they provide funding and services to. FMCSs have created their own interpretation of the rules and then go unchecked. There is no support for overworked CCSs to get every person's services right. They are the only ones allowed to input service requests, and other documentation. CCS agencies have high staff turnover, and employers have been assigned new CCSs as often as every few weeks. Support brokers and other vendors. Next slide, please. Support brokers and other vendors are not receiving pay for the services we provide in a timely manner, or sometimes not at all. As support brokers, we assist employers with completing reimbursements and funding disbursements requests to be submitted to the FMCSs, not because we want to or because we're trying to siphon funding, but oftentimes it's more of a physical support for the person. According to the new SDS manual, providers and vendors, including support brokers, may never inquire to a financial management and counseling service provider regarding more than one participant at a time. This is an inefficient business practice, and non-payment is unsustainable. Systemically, we are trying to maintain quality vendors who want to work with people who are self-directing. This is where we talk about the partnership between traditional providers and self-directed participants. If we have to call and wait on hold for 2 hours for each vendor, this will also impact our ability to serve our customers efficiently. Per survey conducted by SDAN, vendors have had over 150,000 in outstanding invoices collectively. Having each vendor follow up with the employer regarding outstanding invoices rather than going directly to the party responsible for payment of all outstanding balances adds unnecessary stress and takes time away from our employers to successfully lead their services. Due to issues of non-payment and restricted access to solve these issues, support brokers and other vendors have quit, literally, and or denied services to those in self-directions out of necessity. As mentioned earlier by the Secretary and Deputy Secretary, there are many current support brokers who are choosing not to continue. They're not taking their recertification. So far, I am aware of at least 180 participants, who will not have a support broker effective January 1st, even though they are required to have one per the Medicaid waiver. This, as well as other crises, could have been avoided given more time to plan and implement these changes in a thoughtful manner. Next one, please. Next slide. Finally, when resources and services are denied and there are never-ending obstacles in the way, people who need services are forced into a service system they did not choose, such as nursing homes, state institutions, correction facilities, or licensed residential programs. For some, this means navigating a new system where they do not receive the same rights and choices over their service delivery. For others, and this is very real, this means re-entering a system that has traumatized them. We urge our delegates to step in and protect the rights of the people with disabilities to have autonomy over their lives and ensure a successful delivery system. Thank you.
Thank you, Ms. Sawada, for your compelling testimony. Do any members of either committee have any questions for our panelists? Delegate Brian Chisholm.
Thank you, Madam Chair. Irene, I'm just curious if, and I know this could be a tough question, but if you had a silver bullet and could fix the top 3 biggest concerns, because you went through a lot of things, is it a workforce development problem? Do you think it's bureaucratic? Do you think it's policy? What do you think the biggest problem? Because obviously we have a huge problem on our hand, and it's taken a lot of times. I heard you say there's $150,000 in outstanding balance. I don't know how that's covered per employee. how much is owed each employee if we could figure out the average. But obviously, it's a lot of money, and there's a lot of frustration. And I hate to put you on the spot, but I've been listening for 2 hours, and I'm not certain what the answer is because I'm hearing from the Department of Health, well, we're doing exactly what we're supposed to be doing, but it's obviously not working.
I am more than happy to answer that. And if anyone wants to cut me off at any point, that's fine too. So, but I do want to say that I feel like the biggest barrier is the bureaucracy and the processing time. I have read over the audits, the financial audits, and it seems that the issue is that CCSs are not able to do their quarterly visits and their annual plans. That's going to affect the LTSS budgets, right? So, and also the FMCSs have not, historically been able to put in the information on time. Yes, that could be because, some of those vendors are not submitting invoices in on time. We don't know. But the issue is if you get that federal match, financially, the state will be in a much better place. Because I see that a lot of the issue is that the state is not able to get that federal match back because the information is not being sent in on time. So my silver bullet is just get the system going so that we can get that federal match, and then everyone will feel happier and not feel like they have to cut people at the knees.
So we need a more efficient system within the Department of Health to solve the problem, is what I'm hearing from you, correct?
I do, and I feel like a lot of us feel that it is, like worry, of course, I think Maryland spends more on health services than any other service, right? Like we have like a budget of like billions of dollars. Like that, it seems inconceivable. And a lot of that is because of the inflation. But I can tell you, like, honestly, the state is spending just as much in self-directions, if not less. I think that if there was data to show how much of self-directed budget money actually goes back to the state at the end of the plan year, you will see that most people are not spending all that money that we're worried about.
Thank you, Irene. I appreciate it. Thank you, Madam
I
Chair.
appreciate you. Thank you.
Thank you, Delegate. Recognizing Delegate Bagnall for a question.
Thank you, Madam Chair, and thank you for your presentation. I just wanted to circle back and get some clarity on what you said. You said support brokers cannot make inquiries of more than one vendor at a time. Are you saying that if you have outstanding payments that you can from multiple vendors or multiple employers that you can only ask about one outstanding payment at a time? Can you just clarify what that
Yes,
means?
actually, right. We have to have the person on the phone with us when we call now, right? I mean, the ticket system, it's not as difficult because we could send an email and have the person on the email, and that's fine. But with GTI, and again, GTI has worked very well with us, but if we have to call about, let's say, a nursing vendor that has like 10 outstanding invoices, we have to call for each participant because the participant has to be on the phone. And a lot of times, as mentioned in the presentation, the participant has other things to do. They are paying us to help them. So yeah, we have
Thank
to.
you.
So every
Thank
time
you
we
for
call,
that
we have to.
clarification. That
you.
explains it. Thank you.
Delegate Terry Hill.
Thank you, Madam Chair. And Ms. Ueda, thank you for your presentation and for dealing with the frustration. So you mentioned that as of January, I think it was over 100 participants will not have the care providers they need. So the first part of the question is, can you tell me the top reasons? Is because they don't have CPR certification that's up to date? Is it whatever? And then the second question is sort of a follow-up to Delegate Chisholm. What would you change? Would you throw the manual out? Would you simply have it add more time? What would you change if we said you get to write what we're going to ask the department to do to fix this, as expeditiously as or expediently as possible? What would you have us do?
Have we lost our panelist? Oops. What happened? I don't see her. Did we lose our panelist? I think
Not the first time I scared someone away.
Staff is trying to get her, so you can go to the next question, Madam Chair, and we'll come back to that.
Okay, Delegate Harry Bandari.
Yeah, thank you, Madam Chair. I'm interested to learn what is the procedure? How do you maintain accuracy and efficiency in managing support staff payment and schedule? I believe there will be the new limitation on support brokers' ability to access payroll system. Can you share your practice?
Okay, great. I think once we have our panelist back, we can ask her to respond to these questions. I don't.
They're,
Sorry.
they're actually trying to give her a call, so if we can wait a minute, and I
Yes.
apologize because I know I'm in the office.
No problem. Thank you. Thank you,
They
Matt.
say they have her, so she's coming back.
Okay, good. Okay, great. So we'll just pause committee for just a moment. I guess I can use this time to recognize the newest delegate of Health and Government Operations. Delegate Jaden was making an appearance on Chair Pena Melnick's screen a few moments ago. He's quite cute. So we'll take a moment to welcome him to the General Assembly. You seem to
He
have
is so beautiful. Isn't he beautiful?
so lovely. He's so lovely.
He's soothing, you know, you hold him and you feel calm.
Okay, so we'll just pause again until we have our participant back. And I want to also take this moment to thank the panel 4 panel who have been very patient as we have had the opportunity to hear from the 3 prior panels. So,
So she's back.
Welcome
I
back.
apologize. I
No
think I clicked on too many buttons.
We understand and we're grateful for your participation. What I don't know if you were able to hear on a different stream while you were away. We had 2 delegates with questions. Delegate Terry Hill asked, what would you recommend we do in lieu of what is being done now by the department? Do you want the policy manual thrown out? Do you want something else done to help improve matters? And then after you answer that, we'll have Delegate Bandari ask his question again for you.
Madam Chair, the other part was I wanted to know if she could tell us the top reasons why these folks who are not going to have their providers come
Yes.
January.
Yes.
Thank you.
Thank you. Okay.
I do believe there has to be a manual. I agree with the administration that there's too much information in different places and that it's not being shared in a way that people can truly learn and understand. But you can't teach a manual, right? Like there has to be trainings. There has to be there has to be like things in place if you truly want people to use it, right? Like why did we spend time and money, because obviously it's the state's money, to create this manual if we don't want people to use it? In addition, we have to, and then we as because I'm a Marylander, right? Like we have to make more of an effort to ensure that everyone is included. Like where are the other languages? Why aren't we trying? Like how, like there are people, I had to, well, and I'm not complaining, but what I'm saying is that in order for me to get the information out to all the people that we support as a company, we had 8 separate webinars because people have different schedules, people have different needs, different communication styles. We've met with people in person. So that's the kind of attention that our population needs. Sorry. And then why are people leaving? Fear, because being overwhelmed, worried basically. I mean, I know that people are afraid to do something wrong, being accused of, and I'm not going to say that all the brokers are like straight arrows. No. So I'm very, and I feel as a broker, to be honest, someone that's been doing this for this long, and I know that Carol has been doing it even longer, but we want people to be held accountable. If you are someone that's not doing the right thing, and as a community, we're like, why is that person still even operating? That makes the rest of us look like, well, what are we doing, right? So sometimes people just don't understand what the rules are, but sometimes they do, and they're still breaking those rules. And what are we as a state doing to hold them accountable? Anyway, I know I didn't answer all the questions, but
You did a great job. Thank you. Delegate Bandari.
Yeah, just first clarifying question. Given the new limitation, if I understood correctly, on support brokers' ability to access payroll system, right? You guys don't have access to the payroll system. Is that true?
Correct. That's true. That's correct. So if
Yeah,
they have a question about their budget, we can't answer.
Yeah, my question is, how do you anticipate this will affect your ability to effectively assist families in managing payroll, coding, approval for staff hours? Are there alternative solutions or processes you recommend to ensure we can maintain accuracy and efficiency in managing support staff payment and schedules?
That is an excellent question. I know that there's a lot of technology that I keep getting, sorry, my team keeps telling me just answer yes or no, but I can say that we should have accessible means for the participants to be able to approve time, right? Depending on what their needs are. We are not individualizing those services. So if you're living in the middle of the woods with hardly any internet service, how are we helping that person to complete their role as the employer? So it needs to be individualized. That's my answer.
Thank you.
Thank you. Further questions from either committee? I have just one quick one, if I may. Ms. Solana, first, thank you again for providing your expertise and feedback to the committee and to this work. Really appreciate it. My question was related to your comment about how there should be trainings, specifically with the policy manual out now. DDA began the hearing today talking about how they have had weekly technical assistance trainings, multiple webinars, multiple different formats of trainings. Were you aware of those trainings? Have you been able to attend any of them? Have you received support through those trainings? Are there ways that you feel like those trainings should be done differently or improved?
Absolutely. I think that the timelines should have been different. If you put out a manual on October 24th and have it initially was supposed to be implemented on November 7th, and the trainings all took place after that. So, but you're saying if you don't do this by this date, you're going to be held accountable, you're going to lose services. Some of the CCSs still don't know what's happening. Like, so how are, again, going back to what I was saying, is that people are going to be held accountable for something that they haven't even received the information about yet. So yes, the CCSs only received their training, I believe it was last week, and it is today, December 17th.
Okay, and the go live date was pushed to the 21st of November, was my understanding, and it was the go live date for the new forms, which only needed to be completed under 3 specific circumstances, right? That was
well,
the date.
go ahead. I could tell you, sorry, maybe repeat the question.
So initially, the department had set the 7th of November as the go live date for the new forms that were going to be required for 3 specific sets of circumstances, like the approval of new hires or net new services. And then that go live date was pushed to November 21st to allow for more opportunities for public outreach and engagement, including, I know, at least one meeting that happened on the 14th of November, and additional trainings between then and the go live date. So again, I'm just asking, I understand the comment related to the need to have trainings. And DDA has shared with us that they have been doing trainings, but it seems like the comment I'm hearing from you is that it's insufficient. And so, I welcome online, if you want to take this offline rather, to talk more about this particular component, and as well as like working with DDA directly on ways that they might be able to improve the existing trainings that they've rolled out. I think that's a very reasonable, important conversation to have.
Absolutely. I mean, I welcome DDA to work with the Maryland Equity Coalition for People with Disabilities to ensure that the training is culturally appropriate for everyone that is receiving services. Again, I think that there is a misperception that there's not a lot of diversity in self-directed services, but there is. They're just not being accessed or talked to. So having said that, the IFDGS form, even though it hadn't gone live or was not supposed to go live November 7th, November 21st, the old form was taken offline and the new one was replaced. And this was when DDA was still requesting the ABLE account information and special needs trust information. So, it basically put a stop to how those services could be requested. At this time, I have spoken with different communities, and I believe that some of us who work in diverse communities know that there is a mistrust of government, right? So you're asking people to send copies of their bank statements online, and there's no clear indication of who is seeing this information. And I'm sure, but many of you may know, but DDA did have a security breach less than 2 years ago. So, and of course now there's like so much like internet scams and everything. So, I mean, these are really serious and personal issues that need to be addressed and avoided.
Okay, thank you. I appreciate the feedback and answer to the question. And thank you again so much for your participation. Seeing no further questions from our members for this panel, I will transfer it back to our wonderful HGO Chair Pena Melnick to begin the discussion with our fourth and final panel on self-directed services participants. Thank you.
And thank you so much, Chair Chetty. I really appreciate you. I want to just, be clear that it's not a regulation change, okay? Like we have to make sure that we understand that. And for the record, it was basically clarifying what the rules are, right? This is new. We started self-direct in 2023. It's new for the department, it's new for the community. And, we're still learning every day. You're going to see more changes to come. And it's just, I want us to assume that we're bringing our very best forward, right? That the department is bringing their very best, that there's no ill intention. And I want the department to assume the same of the community, and that we're going to figure this out as we go along, and that we're going to clarify things to make sure that you know what is expected, right? What paperwork you need to do, what training you need to take, and just let's give each other the grace to figure that out, okay? I just want to say that. And again, this comes from a good place and a neutral place as well. Ms. Soda, did you have something to say?
I did, and I'm so sorry. I just wanted to clarify that self-directed services has been in Maryland for about 18 years now. It's just that the new waiver, I guess the waiver renewal
But that is what I'm referring
new.
to. I know that it
Yeah.
has been. I've been on the committee for 18 years, but
Yeah,
we changed
okay.
it, right? When did we change
Yes.
it? When did we change it with the waiver?
Well, the July 2023 was effective,
That's
the new
right, and
waiver,
that's why I
right?
said 2023.
Okay.
Okay.
Gracias.
De
Okay.
nada, de nada. Yo sé lo que estoy diciendo, okay?
Yeah,
Pero de
thank you.
todo
Bye.
modo, agradezco, I'm glad that you clarify that, but it's really the changes in 2023. These are the problems that we're having, right? As a
Mhm.
result.
Can I,
And we're
I,
trying to address it. So,
yes.
that being
Uh,
said,
Thank-
went into effect those changes in 2023. We are having some pains in enforcing it and changes. And as I said, and I don't know if you were here when I started, that I wanted this to be respectful with
Mhm.
some humanity, not assuming the worst of each other. It has been very contentious, okay? And I'm not taking sides. I am the chair. I run my committee with respect. I give everyone an opportunity to be heard, all right? And we're trying to
Okay.
find a solution. We could have
Thank
waited
you.
until January to deal with it. We decided, Chair Chetty and I, to have the hearing now, right? Because it's so
And
important. And because
yes, and I hope I
people are,
wasn't disrespectful.
yeah, no, it's okay. People are
Okay.
receiving emails and we are hearing from our constituents. And we want to be respectful to our constituents, okay? And to let our constituents know that we're on it and that we want to give the department the grace to, to deal with the issues, right? Because it's a lot of changes since July 2023. And we want to make sure that they get it right, right? And it's still going to change. We may have to deal with it next summer, again, with something that changes. But my hope is that we can make improvements, okay? And that is the purpose of today's hearing. With that being said, we're going to go to our last panel, which is the self-directed service participants. This is where we're going to hear from the participants themselves and their caretakers. This is where we're going to hear, the advocates, what's working, what's not working. Again, this is not personal. This is their experiences. This is their feelings. Where my husband and I have a disagreement and we've been married 31 years, and he says, I say to him, do not question my feelings. Those are mine. Respect them. And he does the same, right? And I'm asking you to do the same. So we're going to start with Carol Custer, for the support brokers, self-directed advocacy, secretary of the Self-Directed Advocacy Network of Maryland. Then we're going to go to Mr. Rob Stone, who's an artist and an advocate. And then we're going to go to Geneva Stone, who's an author and an advocate. So as you see, we have a lot of diversity. And we want to hear from you. And I want to start by saying that I want to hear from you, okay? I don't want something scripted. I want you to speak from the heart, and I want you to tell me what are the real issues, okay? And you are free to discuss and say whatever you want. This is your opportunity, okay? And we want to hear it from you. With that being said, Ms. Custer, how are you?
I'm fine. I have a script. So because
You
I
could
need
go
to,
with your script, but I want
yeah,
all of you to speak what you're feeling, okay? Not what anyone else may want you to say. I want you to tell me what you are feeling, what you are experiencing, okay?
I would try to add the things that I am feeling and seeing in the parts of the script where they fit. So I don't mess my brain up right now.
Sounds wonderful, and thank you so much. And so let's get started.
Alrighty, so I do have a PowerPoint, but it is not, I'm not reading from the PowerPoint, and you can peruse it at your leisure, or they can fast forward it at the rate they want to. It's just information in detail about the things that we're discussing that that are easier said in a document than in a verbal testimony, because they are pretty weedy, and we want to make this clear what's going on. So I want to thank the chairmen for having us here, and the Appropriations and the Health and Human Services Committee and subcommittees for giving us the opportunity to speak for people who self-direct, and the families, staff, and vendors who support them. Like Delegate Pena Melnick said, my name is Carol Custer. I'm the secretary of the Self-Directed Advocacy Network of Maryland, and I have been a support broker for 14 years. SDAN is an all-volunteer organization formed in 2016 due to proposed changes to DDA's policies and waivers that we believed would have been detrimental to the people in self-direction and could curtail the supports they needed. Unfortunately, we find ourselves in an even worse situation today. After a 7-month study that included experts on CMS policy and many of you on this call, the Self-Direction Act of 2022 was passed unanimously out of both chambers of the legislature. This law was to ensure parity of funding, which had always been a part of DDA waivers, ensure access to that funding, and ensure that Maryland processes and procedures were no more restrictive than CMS required. This work group helped create a law that complied with CMS rules and their vision for self-direction. After the law's enactment, SDAN worked with collaboratively high-level officials in DDA to develop policies, procedures, and forms to implement the act so that people who self-direct could be supported in their own homes or their families' homes and be involved in their community, hire their own staff, set their own schedules, and decide how they would spend funding to support their good life. All this while receiving the supports they need for their health and safety. We are here today because many of these policies, forms, and procedures have been changed in a restrictive manner, and we are very confused about how the department can be allowed to be out of compliance with a law passed just 2.5 years ago, a law that still hasn't been fully implemented, and a law that is in compliance with federal regulations and guidance. There are many detailed issues about the compliance. Hopefully you'll see some of them in the PowerPoint presentation. We believe that these changes violate the law by denying people who self-direct access to their approved funding, taking away their employer authority to hire staff at a wage they determine that ensures high-quality care and provides benefits such as sufficient holiday differential rates that are typical in a 24/7 care model. Wages are often higher in self-direction because there are limited benefits that can be provided to employers, to their employees. We cannot offer a retirement system. We do not have health care plans that people can buy into. So as is typical in other industries, it's wages in lieu of benefits. We also believe that the new procedures is taking away the participants' budget authority to use portions of the service rate for program and administrative expenses that are part of the rate. There is no reason people should have to show that they don't have their own funds to utilize and access the rate for something that they're doing. These changes represent barriers to implementing plans as written and approved. Non-payment of staff and vendors has been an issue since January of 2023, when new fiscal management contractors and processes went into effect. We could have a full meeting on that issue and since that time all by itself. These non-payment issues have only been exacerbated by the confusion brought on by the multitude of changes since January 2024. These changes have slowed down the approval processes and added new steps before payment can be made, which are contributing factors to more non-payment issues. Repeated clarifications, denials, and long delays between them are endangering the supports of many. I have only 6 clients, but one of them has not had an approved plan since January of 2024. The auto extend approved plan, which means that there is a continuation of his services under the old plan, is about to expire. He faces the very real possibility of having no supports in about a month through no fault of his own. Denials of supports that individuals have had for years and that have been justified this year by the nursing and behavioral specialists on their teams have forced people to decide to accept a level of services less than they need or to face the situation I just described. People have been told that they need to accept DDA's changes to their plans or their services may be disrupted. When teams have asked for the criteria needed to support enhanced rates, they have literally been told by DDA, we are not going to tell you. These implementation barriers have caused people and their families to fear what the future holds when family can no longer bridge the gaps of support. These are concerns that the proponents of the Self-Direction Act of 2022 also addressed. The November 2024 manual made changes with no stakeholder input that we have been able to identify. The creation of a manual and its context were a complete surprise. It goes beyond many of the changes we had already observed since January of 2024. These changes will not, as DDA representatives have stated, help reduce processing delays or ensure care providers are paid in a more timely manner and participants receive the level of care they need. In fact, the opposite is true. These changes are unnecessary because monitoring and accountability measures are and have always been in place in self-direction model. Every expenditure is reviewed and dispersed by the fiscal management agencies who are DDA contractors. DDA's approval is required for the person-centered plan that determines the approved budget and the budget sheets and other forms of that allocate the funds. Reasonable and customary wages for employees and vendor rates, which are now included in the manual, have not been increased since January of 2023, thus denying those who self-direct access to 2 rate increases since that time, 8% in January of 2024 and 3% in July of 2024. This practice deviates from previous DDA policies and denies access to funding, which is another violation of the Self-Direction Act. A request for payment of an unauthorized item or service is not fraudulent. It could merely be a misunderstanding of the rules that have been changing constantly since January. The manual sets out situations in which people can be removed from self-direction. Some of the conditions could be seen as being a form of competency testing, which is prohibited in the Self-Direction Act. Proper support and training can eliminate many issues. And to answer some questions that came before, people who work for people who self-direct, staff that work for people who self-direct are trained very explicitly on the needs of that staff of that individual. If they have a behavior plan, they learn the behavior plan. If they have medical issues, they learn the medical issues. They have to have the basic CPR first aid training. But if there was a mental health issue and they needed that specific type of first aid training, they would get that first aid training based on the recommendation of their behavior specialist. So it is very person-centered, specific training for that one individual. People who self-direct in Maryland are hurting. They are confused. In some cases, they are terrified that the wonderful lives they have built, full of choice and self-determination, are in jeopardy and will not be able to be continued as they want and need. Self-direction will collapse if the infrastructure continues to be eroded. What will happen to the people who self-direct if it does? According to discussions yesterday in a town hall regarding services through community providers, people receiving those services are dealing with many of the same issues, including reduction of previously approved supports, challenges to getting needed supports, loss of flexibility, changes in policy implementation, and lack of communication with DDA. The nationwide shortage of direct support workers limits these providers' capacity to absorb the 4,000 displaced people from self-direction. What is the state's plan to support people to remain in their home or their family's home? Will people be forced into more restrictive settings, not of their choosing? Self-directing Marylanders deserve support and respect to remain the service model they choose. We asked for a legislative audit of the departments complying with the provision of the Self-Directed Act of 22. We asked for a work group tasked to perform an in-depth analysis of the issues related to funding and processes in self-direction because of the many specific issues that have emerged and that you're hearing about today. We asked that the department return to policies and processes in effect in December 2023 until these reviews can be completed. We recognize that Maryland has financial issues. Let's talk about that and not take away needed supports that have been in place for years, resulting in the individual's health and desired outcomes for their lives. Self-direction is cost-effective. Self-direction can seem very complicated. SDN stands ready to get into the weeds to bring understanding of the benefits of the service model and ensure fiscal and program integrity. Thank you for your time and attention to these issues. I invite you to look at the PowerPoint and other documents that I submitted, and I'll be happy to answer any questions that you have.
Thank you, Ms. Coster, for your time and all your efforts. I really appreciate it and your expertise. We're going to go on to the next witness, and then at the end, we will go ahead and open it up for questions. Okay, so don't go away. Next, we have Mr. Stone. Will you be so kind, unmute yourself and give us your testimony? And good afternoon. And I want to thank everyone for their patience. We're holding tightly, and I really appreciate you. We have, after this witness, just one more, so hang tightly. Thank you so much. Go ahead, Mr. Stone.
Robert uses assistive technology to communicate. He's non-speaking,
Yes.
so you bear with us a little bit as we
Yes.
move the device.
Yeah.
Okay, go ahead. Got it? Is it not seeing your eyeballs? Oh, there it is. Sorry,
It's okay. Take your time. No need to rush. We're here. Do not worry about it, okay? Take your time. And we're grateful that you're with us today and that you're able to tell us and give us your experience.
My name is Rob Stone. I use he, him pronouns. I'm here to represent people on the go. I'm an artist and an advocate for healthcare and disability rights. I live in Bethesda, Maryland with my family. Thank you for inviting me to speak to you about my experiences with self-directed services. I am 27 years old, and I am fighting for me and other disabled people to live with dignity in our communities. I rely on lots of different care workers, my home nurses, my direct support professionals, and even my parents. People in self-direction need to be able to choose family as staff. Some people are more comfortable with family. As for me, my parents provide important backup, because my RM and my DDA services cannot be coordinated. My mom will explain this later. I have very complex needs, and so do many others in self-direction. Everyone in self-direction needs flexibility to pay higher staff wages and give raises. Traditional providers can offer health insurance and retirement plans. We cannot. For many people in self-direction to hold on to staff, the reasonable and customary rates are too low. Because I need family as staff, I must have a support broker. As you have heard, the new DDA policies prevent my support broker from really helping me. I cannot enter time because the FMCS portals are not accessible. They do not meet federal requirements for accessibility, including screen readers and switch access. Matt Rice says that the support broker is kind of like a tax preparer. You give them what they need to do their job and leave them to it. Because I need family as staff, I must have a support broker. As you have heard, the new DDA policies prevent my support. Finally, everyone in self-direction has had a lot of difficulty communicating with the DDA and MDH. They don't really listen to us. Can we please have a work group for self-direction and also to help coordinate programs for those of us with complex needs? Thank you for letting me speak. I'll turn it over to my mom now to tell you more about the REM program. Finally, everyone in self-direction has had a lot of difficulty communicating because I need.
Sorry, we had a
family as
misfire
staff.
there.
I must have
It's okay. Don't worry about it. It
Right.
happens. It happens
Yeah.
when we do these virtual meetings, you know, we lose people. We have to be patient, and thank
Yeah,
you for being with us. How are you today?
I'm doing well, thank you.
That's
And
good.
everybody for letting us speak today. I did submit to the committees
Yes,
a
we received it.
that outlines
Yes.
the problems and the issues. And after listening to everyone speak today, what I really wanted to address is an issue that's germane and essential to ensuring that people with complex medical needs and all people with disabilities have access to their communities and services can be coordinated and all of that. And forgive me because I'm going to speak extemporaneously, but briefly. So Rob and I do federal advocacy as well as state advocacy. And one of the things that did not come up today is that the reason for the DDA waiver programs and the REM program as well are to protect the civil rights of people with disabilities. And they're especially their right to live in their community where they belong in the most integrated setting appropriate to their needs. And I do want to just make a note that I think the secretary probably realized she misspoke. The DDA waiver programs are Medicaid programs. They're all Medicaid programs. And I also would like to respectfully disagree with her and with quite a number of people at MDH. The state tends to try to separate habilitative care and medical care as though there is some absolute distinction. That's not really the case because habilitative care means the care that you need, say, to be at home and be in your community and live. Well, Robert has a tracheostomy, he has a G&J tube. He has a portable feeding pump, he has a portable suction machine so that he doesn't have to be confined to a bed in an institution. So, and having the right level of nursing care available also helps him live in his community. And in fact, the REM program is designed to prevent institutionalization by providing medical services at home for certain parts of the population. So sometimes when states are very engaged with making sure that their programs meet Medicaid standards and rules and so on, and as the saying goes, right, sometimes you can't see the forest for the trees, right? So the forest here are the civil rights for people with disabilities. And while Deputy Secretary Hutchinson noted that correctly, that there haven't been any federal changes to the home and community-based service programs, which are the DDA waivers, there actually has been really important changes to federal civil rights law for people with disabilities. And let me just briefly explain that. Robert and I, he's over here, were honored to be able to go in May to the press conference at which Secretary Javier Becerra introduced the revisions to the 504 regulations, which were substantial and had not been done for 50 years. And these incorporated Section 504 is the cornerstone of civil rights for people with disabilities. And updating the regulations meant incorporating the ADA, the Olmstead decision, and many other pieces of federal civil rights law to ensure that people with disabilities are protected. Now, the name of the Section 504 program, sorry, I've got a whole bunch of notes lying around here. It's called non-discrimination on the basis of disability in programs or activities receiving federal financial assistance. And in this case, the federal program is Medicaid. So, so the whole goal here is to prevent unnecessary institutionalization. Now, with the way that the state has set up stovepipe systems, the REM program and the DDA waivers, that puts Robert at direct risk of institutionalization every single day of his life. Because there is no option, long-term care option for him other than an intermediate care facility, and that is an institution. Medical day programs and medical group homes are also institutional settings. So the key to all of this, and I won't read it all, but it is the integration mandate, which is embedded in the 504 regulations. And I'll just read a couple of pertinent passages, okay? A recipient shall administer a program, and the recipient in this case is the state of Maryland, shall administer a program or activity in the most integrated setting appropriate to the needs of a qualified person with a disability. Note here that needs is not qualified. It's not just medical needs, it's not just social needs, it's the whole scope of the person's needs within the community. So it would be unfair to segregate people with medical needs from other people with disabilities. And then also it's a long section, and I can forward all of this to committee members if they wish later. Okay, so the last section 4 of the integration mandate says failure to provide community-based services that results in institutionalization or serious risk of institutionalization. This paragraph includes, but is not limited to, planning, service systems design, funding, or service implementation practices that result in institutionalization or serious risk of institutionalization. Qualified individuals with disabilities need not wait until the harm of institutionalization or segregation occurs to assert their right to avoid unnecessary segregation. And that last piece was the most important update to the integration mandate, because in the past, Olmstead cases have been decided based on a risk of imminent or immediate institutionalization. But under federal law now, all people with disabilities who are at future risk of institutionalization, may bring Olmstead case, a lawsuit against the state. And the state can be said to be violating their civil rights. I understand that's a legal process, however. And we spoke about cost neutrality also. And I just want to caution everyone here that when we're talking about cost neutrality in the Medicaid programs, that's not a one-to-one comparison of participants' budgets. That's a comparison of the entire home services for people with disability in the state compared to the total of the institutional costs in the state. So that's an important thing to remember, so that we're not discriminating against people because one person has a budget above a certain threshold, et cetera, et cetera. It's the aggregate. And furthermore, I also wanted to point out that I read all 600 pages of the 504 regulations. And I also read the federal guidance that was issued along with them in the Federal Register. So the guidance says the civil rights obligations created by Section 504 are separate and distinct from the requirements of Medicaid and Social Security Act, the Social Security Act. So, and it continues, compliance with Medicaid requirements, those are all these rules that we're talking about, does not necessarily mean a recipient, in this case the state, has met the obligations of Section 504. So what the federal government is saying, and this is what Javier Becerra said in his remarks, is that we've got Medicaid, we've got all these program rules, we've got all these different state programs, but the state also has to be in compliance with civil rights law. And that's a separate form of compliance. So I will, is there anything more I wanted to point out? Yes, I mean, so that's really why we're all here today, right? Is to ensure that people with disabilities have access to the most integrated setting according to their need. That's what these programs are for, includes the REM program. And that's why it's really important that we look at coordinating complex care for people with disabilities, because in Maryland, currently, anybody living at home with complex medical needs is de facto at risk of institutionalization. I have that in writing from Don Williams, who is one of the directors of the Division of Nursing Services. And I will stop there, and I'm happy to take any other questions on the REM program or anything else. Just let me know what you need. Thank you very much.
Thank you very much, both Rob and Geneva Stone. Thank you. We always appreciate hearing from you in our committee. And certainly do not take it for granted. I'm going to open it up for questions now for all the panelists. Are there any questions from the members from both committees? Okay. I don't see anyone with their hands up. I think your testimony was very clear. It does not mean that we are being disrespectful or because you don't get any questions, does not mean it's not important. Sometimes it means that you drop the mic and it's done, so to speak, as my kids will say. I'm learning from my young ones. That being said, I do want to thank everyone for being here today. We don't have the answers. This is the beginning of a conversation. I know we have a session where we will continue to work on these issues. I'll speak on behalf of both committees. So this is not the end. These are very complex matters. They're very complex because you have, a community that is going through a lot, a community that has a lot of medical needs, emotional needs, physical needs that need to be taken care of, and we need to be supportive. You have a department that is trying to manage a lot of people, right, with complex matters. You have a budget as well, right? And they're trying to figure it out. They're trying to put out rules to make it clear, right? It is going to always be changing. And I just ask patience from both sides, right? And for grace from both sides to sit down. I ask for both sides to please, in the spirit of the holidays that are just around the corner, to just have faith that we will get to it and then we will try to figure it out. And I don't want you to leave here not thinking that we did not listen. And those that are watching on YouTube, those 300 and something people that were watching, know that, the committees stay on. It's almost 4 o'clock. And that we were present and paying attention. And we asked questions. And didn't ask questions when we thought that it was clear, okay? And that you're always welcome and can reach us. I know you're emailing us and we are being responsive to your emails as well. But please give us time, all right? We're in session January 8th. Give the department time to figure it out, all right? And as always, if you need anything, you can call us. And I want to thank my colleague for your time and your efforts and your questions, and for being here today and for being present. And I'm so grateful for that. And for the panelists, everyone that testified, I hope you felt respected and that you felt heard. And know that we certainly don't take it for granted. To the department, thank you for being willing to work with us and for being at the table and for being willing to improve on some of these requirements, okay? And on the process as well. Chair Chetty.
As we like to say in Annapolis, me too. And happy holidays to everyone. Thank you.
Thank you. Have a blessed one, everyone. Take good care of you, okay? And thank you for all you do. Bye-bye. To staff, thank you so much for handling the slides, okay? Bye-bye.